Good morning, good afternoon, and a very warm welcome to all of you at the start of this very exciting conference on scaling up mental health services within primary healthcare. We are really humbled that so many of you are taking the time to join us, to share your experiences, to learn lessons from one another, and to learn together. Please use the chat to say hello and also to share your questions and perspectives. I am really happy to co-moderate this session with my colleague, Dr. Ledia Lazari, who is Regional Advisor for Mental Health and Wellbeing. Ledia has been a true engine to accelerate WHO's work on mental health and shaping our mental health flagship program with a unique coalition of partners. You will hear from her in a moment, but she gave me the go-ahead to continue with the introduction. Our conference will be spanning over 2.5 days, and it is really very, very timely. I am looking at this wonderful online forum, and I'm seeing that we are more connected than ever. At the same time, we are also more isolated than ever. And this is taking a very big toll on our mental health. This conference is really how to strengthen our approaches close to people's homes, schools, and workplaces to support them so that we can respond better to this new reality and see people's health and mental health holistically. With this, I would like to extend a warm welcome to Dr. Natasha Soparti-Muscat, Director of the Division of Health Systems in the WHO Regional Office for Europe. Side by side with our Regional Director, Dr. Hans Kluge, Natasha has been a great champion of the cause of mental health. Natasha, the floor is yours for welcoming remarks.
Good morning, good afternoon, good evening to everyone, and to Melita and Ledia and your teams. Thank you very much for working to put this mini conference together. It's indeed an honor and a privilege to be here to open this conference on behalf of our regional director, Dr. Hans Kluge, who unfortunately is on duty travel today and would have very much loved to be here with you all. Of course, under the first European program of work, mental health was one of our flagship initiatives. Under the second European program of work, primary healthcare is a special initiative, and this mini conference focuses very much on these two areas and the interface. Why is this so important? Because every family, every community, at every stage of our life, mental health and non-communicable diseases are leading causes of ill health in our region. And our data shows just how early this burden begins. In fact, a new report published on the mental health of children and adolescents in our region shows that 1 in 7 young people lives with a mental health condition. Furthermore, suicide has now become the leading cause of death amongst adolescents and young adults in our region, those aged 15 to 29. And sadly, we know that far too many young people still do not receive the timely quality support that they need. Looking at the other end of the life course, looking at older persons, loneliness is on the rise. 1 in 4 people over the age of 60 feels lonely. 1 in 3 is socially isolated. Why is this important? Because we know, we have evidence beyond doubt that loneliness increases the risk of death, increases the risk of dementia, which already affects 14 million people across our region. So mental health is central to our priority on living and aging in good health under the second European program of work. Reversing these trends means acting early. It means supporting people in schools. And tomorrow, actually, we have an important event where we are relaunching our health promoting schools network. And it means challenging stigma wherever and whenever it appears. The pressures on mental health systems are only increasing. Climate-related events, conflicts and wars, health emergency, and this isolation brought about by the increased amount of time being spent also connecting virtually in our world. All of this is bringing disruption, distress, and difficulties. So with the focus now on primary healthcare as a special initiative, this presents an important opportunity to strengthen the foundations of mental health. Primary healthcare is very often still the first point of contact for most people, and probably 1 in 3 presentations has a mental health component, if not is presenting as a mental health complaint to start with. Primary care, of course, is the place where trust is built and maintained, and where early identification, support, and appropriate and timely referral can make a big difference. When mental health is part of primary care, is embedded in primary care, conversations become part of routine practice. Stigma is reduced. And in this way, people can present earlier and can be sent to receive appropriate care and support earlier. In fact, let me be very clear that when we are talking about mental health being embedded in primary care, we are not talking about replacing specialized services where these are clearly needed, but more about providing an early identification and diagnosis and providing complementary low-threshold services. But we want to see mental health integrated not only at primary care level, and when I say primary care level, I'm also talking about community health teams, but also in general hospitals, where we still see that there is a long way to go, because it's by embedding mental health along the continuum of care that we can really see results. Yet, our recent survey of 29 countries in our region, mostly in the western part of our region and EU countries, shows how far we still have to go. Only 6 countries in the European region have fully enabled mental health prevention, promotion, and treatment within primary care. Only 7 have fully transitioned mental health services to community care. And only 11 countries have specialized services delivering mental health at the community level. And only 15 provide acute psychiatric care in general hospitals. Of course, these figures are linked. It's a chain. And what do they show? They show that far too many countries in our region still have mental health services concentrated in high intensity, which, where appropriate, may not necessarily be a bad thing, but very often it's high intensity stand-alone institutions that perpetuate isolation and almost build a firewall from the general health sector. If we want to move decisively away from these outdated asylum-based models, we must expand community services as an alternative. And today we will continue the discussion we started last April when we launched our policy paper. And we get more operational by reviewing 4 practical strategies to scale up mental health through primary care, recognizing that countries are still struggling to do this. These strategies that you will hear more about are grounded in evidence, but also shaped by real-world country experience. And you'll hear more about these today. They offer a roadmap for making mental health services more accessible, more integrated, more people-centered. But the country examples will show us that these are not merely buzzwords or jargon. So last year, with the support of the European Commission, we gathered in Paris for the first time to see how we can mainstream mental health across all policies. 260 participants from 31 countries, remarkable in itself, but still more remarkable, from 13 different sectors came together from education to justice, from digital sectors to urban planning, from agriculture to transport. Because the message was clear. Mental health is not the responsibility of the health sector alone. Indeed, building mental health resilience, which is so key and so critical, is a responsibility across the whole of society. But for the whole of society to take that responsibility up, it needs leadership from across the whole of government. And this spirit of collaboration, of bringing mental health out of the silos and of making mental health everybody's business, was born through the Pan-European Mental Health Coalition, a coordinated platform that brought together governments, practitioners, civil society, people with lived experience to work collectively together. EPW2, our second European program of work, now builds further on that foundation. And let me close by saying that at WHO Europe, mental health remains a key priority for us. In fact, you will find it under the priority of mental health and non-communicable diseases, but you will find it under the priority of living and aging in good health, under health systems transformation. And of course, mental health is part of health security, and dealing with the impacts that climate change has on the mental health, particularly of younger people, remains a priority. Today, we focus very much on the nexus, mental health and primary care, but you will see that mental health is across the whole of our work. I am confident that through the work that has been done and through the work that is planned going forward, we will remain in a strong position to be at your side, to provide the technical expertise, to exercise our convening power, bringing countries together to share experiences, to inspire each other, and we will continue to accompany you along your journeys to truly mainstream mental health in primary and community care, because this is where we can make a difference in the way in which we build mental health resilience in our societies. We recognize early, we fight against the stigma, and we ensure that through appropriate and timely referrals, we can also give the necessary mental health support according to the nature of the conditions. So mental health is a public health issue, but mental health is also a condition that requires the right clinical support in the right place, delivered by the right practitioners. And that goes very much back to the heart of our strategy for resilient and sustainable and equitable health systems. Thank you very much for giving me this opportunity to open this important mini conference, and back to you, dear Melita and Ledia.
Thank you. Thank you so very much, dear Natasha, for giving us, also on behalf of our regional director, Dr. Kluge, the overall strategic vision of WHO Europe about placing mental health at the center of both EPW1 and now EPW2. I'll take one point from your intervention. You mentioned that WHO Europe has tried during EPW1, but also now, to lift mental health out of the silos, and the collaboration between the mental health and well-being team in WHO Europe and the primary health, the office on investing on primary healthcare led by my dear colleague Melita here, is indeed an exemplary moment of bringing mental health out of the silos and working consistently across various programs and divisions in our office. Without further ado, I have now the pleasure to introduce Dr. Viviana Bianchi Martinez, who is the president of the World Organization of Family Doctors, WONCA, very known for all of you, for all of us who have practiced in any capacity in healthcare. Dr. Bianchi, the floor is yours. We are keen to hear your intervention.
Thank you very much, Lydia. Good afternoon, good evening, and good morning to colleagues joining from across the WHO European region and the world. It is a true privilege to be with you today on behalf of the World Organization of Family Doctors, WONCA. I would like to thank our colleagues at the World Health Organization in Europe for convening this important mini-conference and for your continued leadership in advancing mental health within the primary healthcare approach. Today and tomorrow, we're not only talking about what needs to be done, we're focusing on what and how we make it happen. And that shift from vision to implementation is exactly what our communities, our patients, and our professionals are needing. Mental health needs are rising everywhere. In the WHO European region alone, more than 125 million people are affected by mental health conditions shaped not only by illness, but by conflict, displacement, economic uncertainty, and the lasting impacts of the pandemic. And yet, too many people still face barriers to care, delays, fragmentation, and stigma. From a WONCA perspective, this is not a new challenge. Family doctors are already providing mental health care every day in every community and often with limited resources. We see the anxiety behind the headache, the depression behind the chronic disease, the loneliness behind the consultation. And we walk with our patients over time, sometimes for years and sometimes for generations. Primary health care is where our mental health belongs. It is the first point of contact. It is a place of continuity and trust. And in strong primary care systems, mental health concerns represent a large share of what we see every day. This is why family doctors are essential to closing the mental health gap. The WHO policy paper gives us a clear and practical path forward and strengthening the mental health competencies of the primary care workforce, integrating mental health professionals into primary care teams, improving linkages with specialist services, and working across sectors to address the social determinants of mental health. From a WONCA perspective, these are not abstract strategies. They are what make care possible in real life. Scaling up also means delivering the right care at the right time. A stepped approach where many people can be supported in primary care and in the community, while ensuring access to more specialized services when they are needed. But we also need to be honest that family doctors cannot do this alone. Despite the growing need, mental health still receives only a small fraction of health investment, and that without financing, training, and team-based care, we will not achieve the transformation that we are all calling for. Mental health is shaped, but more than healthcare alone. It is influenced by the conditions in which people are born, grow, live, and age. And this is why the primary healthcare approach with strong community-based services and multi-sectoral collaboration is so essential, because care close to where people live is more accessible, more effective, and more respectful of the dignity of people. At WONCA, we stand ready to partner, to strengthen the primary care workforce, to support education and training, and to help build integrated, people-centered systems of care. Together, let us move from commitment to implementation. Let us build systems where mental health care is accessible, integrated, and person and community-centered, because there is no health without mental health, and there is no strong health system without strong primary care. It is now my great pleasure to welcome all of you, my dear colleagues, to this mini conference on scaling up mental health within the primary healthcare approach. I wish all of us a rich, productive, and inspiring meeting, and I look forward to the ideas, the collaboration, and the shared commitment that will emerge from our time together today and in the future. Thank you so much.
Thank you very much, dear Viviana. These were very inspiring words and warm words at the same time. And indeed, I want to thank WONCA for this great partnership and for really this truly partnership process of how we prepared this conference. And together we can reach so many people with very important messages. What I really liked in your narrative is that you really started by focusing on people. And throughout today, I will keep bringing us back again and again. When we consider service design, let's think about the people and the population for whom we're designing these services. And that really enables us to transition to the next part of our opening session, where we will have two very interesting keynote presentations that will set the stage for the whole of the conference. During these 2 days, we will engage in very interesting sessions on how to strengthen the model of primary healthcare to deliver services, better mental health services, how to strengthen health workforce policies, financing policies, how to strengthen and use well digitalization. But in these keynote sessions, let's start with focusing on the population and the people we serve. I have the honor to introduce Professor Christos Leonis, who is Professor Emeritus in General Practice and Primary Healthcare at the School of Medicine, University of Crete, Greece. Professor Leonis is going to share with us some thoughts about how to move mental health services closer to the people and what is the role of primary healthcare addressing mental health conditions across the entirety of the life course, considering not only diagnosis, but the conditions within which people live. Professor Leonis, the floor is yours.
Thank you very much, Dr. Jakob. I feel very privileged for many reasons. First of all, for the moderators, I truly feel privileged having two important WHO officers in moderating this important session. But also, I feel very privileged just following two important leaders, one from WHO, Dr. Azopardi, and also Professor Viviana Bianchi. I feel very privileged on behalf of a WONCA working party on mental health, one of a strong working parties working under the umbrella in the family of WONCA to address and a little bit offering some few messages based on evidence, based on our experience, on the challenging discussion we're having together in the working party. And at the moment, also, I'm warmly thanking all the WONCA working party and the CEO and my colleagues in that group. Many thanks also to Dr. Pirova and Dr. Inestrova for helping and assisting. Next slide, please, Dr. Pirova. I'm just trying a little bit. Next slide. Yes. I'm not in my intention in discussing and all of that with the letters prepared, but just only based on this slide. It is important saying that a very high number, that of course varies in settings, of mental health needs, of mental health problems are still non-recognized and still undertreated. I think this is the key message for frontline practitioners and family physicians. Next slide, please. It is important, of course, just addressing the challenging for us. And talking about the challenges, it's important started with the barriers. There are many barriers we needed to focus on discussing. We're having barriers regarding the workforce and resource shortages. We're having barriers relating the stigma across many settings and discrimination that people with mental ill experience. We're having financial and systemic gaps, many of the barriers well known in literature. I'd like also just in adding one important barrier for us, that's a WONCA working party suggesting under the support of WONCA steering committee is the lack of training. we needed in having in front of us well-trained family physicians in meeting all of these challenges. Next slide, please. And also another challenge is a little bit addressing the determinants of health and giving a more emphasis on the social and environmental determinants. In family medicine and in primary care, always you're discussing about psycho and social and potential cultural background of health. And it is quite very important, a little bit stressing and turning the attention of frontline physicians that social determinants and especially psychosocial determinants are of important value. Next slide, please. I'm not thinking if just widely the term of social determinants has been widely understood. It is very, very important just reminding the definition given by WHO that the social determinants of health broadly defined as the conditions in which people are born, grow, work, and age, and people's access to power, money, and resources have a powerful influence of health inequities. It is very important in stressing the individual capacity, and among individual capacity is very important in stressing the message of WHO about the importance of health literacy. In the right corner of this slide, you can find some empirical research carried out in Southern Europe, in Greece especially, which just highlight how close is health inequalities with socioeconomic conditions. That means low socioeconomic condition potentially or usually predicting low health literature. Next slide, please. But also another chance in this framework when discussing the social determinants is how we could translate the psychosocial determinants of chronic disease. Already by our leaders, already you heard about the non-communicable disease, and mental health is a part of a non-communicable disease. But the challenge is now how to translate all of this in statements, in recommendation to our people, how to change or adapting a lifestyle in reducing the risk of chronic disease or manage better. And I think there are a lot of key concepts at the moment that we need a little bit stressing their attention. And this is a meaning in life. It is an easy job to translate chronic diseases, experience, suffering to meaning in life. I think that is another challenge. Next slide, please. But as a family physicians, please. Okay, I think that is a key concept now, is a life course approach. As a family practitioners, but also as a frontline in generally therapist, we needed to in focusing on life course and giving a more focus that the life course is strongly related with health and well-being, depending on interaction with the multiple protective and risk factors. And on the right corner of this slide, this is how important it started from human early life course, giving more focus at the beginning of the age of birth, thus to giving more continuous understanding of the life course. And that's now it's the bottom on the top of the research is the so-called exposomes, and social exposomes is an important part of a life course approach. Next slide, please. And to offering this focus on life course, it is so important to visit another important concept for family practice, for primary care, is a concept of suffering. It is a feeling, it's a painful experience, it's difficult to be measured, but at the moment, it is so important a little bit to focus and turn the attention of frontline physicians understanding the concept of suffering and potentially as a starting point in the natural course of any disease. But just focusing on suffering, we needed a family physicians well equipped in motivational interviewing and also in provision of compassionate care. Compassion and motivation is important tools at the hands of primary care practitioners and family physicians. Next, please. And it is an easy job. Potentially all of that you're hearing at your ears as statements or rhetoric statements. That means we needed more on policy, on health policy. And that is the second part of a keynote presentation immediately after my contribution. Next, please. And thinking and talking about action, I just a little bit turning our attention at WONCA, the role of WONCA. The role of WONCA primarily is in enhancing and making family physicians more equipped, in providing books. That is one of the recent book of WONCA, challenging in primary mental health care, providing and supporting and sustaining interdisciplinary work, but also just providing testing and evaluated digital programs. One of them is MDD Minds, that's spread out all world regions, and initially the first two publications have been already published and presented in literature. Next slide, please. But many times you heard about scaling up the mental health services in primary care approach or integration of mental health into primary care. I think that everybody agreed about it, but it's very, very important to convince the policymaker, the stakeholders in health, how easy is that job. And we have discussed, next slide please, in a WONCA working party. And we're thinking that the Astana Declaration, this fantastic strategic direction of WHO, it is also have been discussed among us and already discussed how important is the family physicians to be well placed in patients' vulnerability and checking the impacts of poverty and disadvantage. Already we discussed in this consensus paper immediately after the Astana Declaration how we could just achieve multi-sectoral collaboration with a focus on factors including many of that already discussed to reduce chronic stress, poverty, and health inequalities. Next, please. But still, I'm thinking, next slide, please. Thinking that is not an easy job. Still, we needed, not just the previous, thinking how to translate all of these statements in behavior change. I think behavior change is a key issue, and it's actually one of our important role. Not just a simply words, not just a simply sympathy or empowerment. We needed skills, skillful family physicians in changing the suffering, translating the suffering in the meaning of life, in the purpose of life. I think this is the challenge. But also to achieve it, it is very important in making bridge with other medical specialties, with other healthcare practitioners. And this is an example of our working closely with cardiologists. European Society of Cardiology established and published a consensus statement at the moment how mental health is related with cardiovascular, and we started thinking all of this chronic stress, how it could lead and guide to coronary artery disease and cardiovascular disease. And I think that is another chance, another challenge is just establishing bridge with other disciplines, medical and health disciplines, included gastroenterologists, included respiratory physicians and practitioners. Next slide, please. But also our task is not only just always mentioning or focusing the negative determinants. The role of family physicians always in focusing on health asset, empowering the people, taking at their hands their privilege, the privilege based on the culture, on the spiritual environment, and making or translated them as a positive well-being, as a positive thinking. And this is as part of this publication where just we establishing a partnership of a family physicians, a primary care practitioners with a psychologist, psychiatrist, cardiologist, and other specialties, and of course, primary care practitioners, nurses, health visitors, etc. Next slide, please. I think, of course, now it's the last slide, just the slide before. It was just engaging a strategy together with patients. The slide that's now almost omitted, it was just giving a focus on the role of primary care practitioners with the patients. Just started with the patients and closing with the patients based on the patient's preferences and wishes. I'm enjoying very much, I feel very privileged addressing this couple of slides in front of so eminent colleagues and so many important colleagues across the world. Thank you very much.
Thank you so very much, Professor Leonis, for this very inspiring presentation. You remind us not only of the evidence of why we need to apply mental health, mainstreaming mental health in primary health care, but you also issued a very a strong call about the values. Why? You talked about compassion, you talked about the values of solidarity. So this was precious to hear from your presentation. So thank you very much for that. I want to notice, before I pass the floor to the next speakers, I want to notice the fact that we have participants from all over the world. And I want to mention that the presence of so many people from so many continents of the planet, in a way, is a reminder that primary healthcare is without borders, mental health is without borders. So to all those that say, but my country has a particular culture that your approach would not be fitting there, the presence of so many of you from all over the world is indeed the response to that. And I'm now going to, Professor Leonis mentioned the policy brief that WHO published last April, so less than a year from now ago. We, both our teams, dear Melita, you and the team, and also us here in Copenhagen, we were able to work with so many other partners around Europe to come together to a number of strategies to propose to countries about how to scale up mental health within a primary healthcare approach. I'm delighted now to introduce my two colleagues, Zulfia Pirova and Anna Maria Tijerino Inestrosa, who are respectively seated in Almaty and in Copenhagen, for giving us a flavor of the policy brief and of the related strategies. Over to you.
Thank you very much, Lydia, and thank you all once again for joining us today. If we can move to the next slide. We wanted to introduce the second part on the strategies, showing you as well what happened 2 decades ago was the first World Mental Health Report that was published in 2001, where you could see, actually some of you might be familiarized with the pyramid of services, how mental health services were structured and how they were actually organized, going from self-care and finally ending in long-stay facilities and specialized services. Can we move to the next slide, please?
I can't move them.
Thank you. We'll find the next slide. Otherwise, I will continue. And this World Mental Health Report that was produced in 2001 was actually updated 2
Что-то вы мне
decades.
здесь сделали, у меня слайды не двигаются.
Good, I will continue. Yes, I know slides in English are not changing, so let's bear with us a little bit while we fix the challenge. Now it's working. So here you will see the report that was produced in 2001. And I was talking about this pyramid of organization of mental health services that some of you might be familiar with. Next slide. But now, 2 decades after, there is a new World Mental Health Report that was launched, and it shows a different organization of services. And it's powerful to see this type of diagram. Sometimes the point might be overlooked because it's true that no single service or sector can meet the full range of mental health needs on its own. So here, primary health care, which is highlighted deliverable, it's part of these different hubs that needs to be connected. And there are main three interconnected words, which is the general health care, the community mental health services, and the mental health beyond the health sector entirely, spanning around the social services, the housing, employment, school, and more. It's true that the message might be simple. It's not that we are complicating our life, but this message is that a mix of services and support is extremely needed. Someone living with a mental health condition might need medical care from their GP, but as well might need psychological counseling, might need peer support, help with housing, access to vocational assistance, and sometimes, often, all of these at the same time. So a system cannot only offer one of these, otherwise it will fail and will have multiple gaps. And this is the role and this primary healthcare has a big role in this ecosystem. It's not to do everything, but it's to know what exists, make the right connections, and ensure no one falls between the gaps. Next slide, please. Dr. Natasha Supardi-Muscat talked to us already about this report on the mental health services, on the systems, mental health systems capacity. That was a survey that we did within 29 countries in our region. And this report is showcasing how today still more countries that we assume they're quite advanced in the offer of care, especially in their offer of mental health care, that still relied heavily on specialized services and on big institutions. Still need to invest more in prevention and promotion, but also in the treatment of mental health conditions in primary health care. So the message here is clear. We need to shift the center of gravity of mental health care away from hospitals and institutions and towards integration, intersectorality into primary health care, into communities. And it's just not just a technical reform or a structural reform, but also because it's a matter of right, of equity, and of human dignity. Sophia, I pass over the floor to you.
Thank you very much, Anna. Good afternoon, dear participants. I think that Dr. Natasha Zapardi was quite explicitly outlined that mainstreaming mental health through integrated community-based approaches is at the core of the new European program of work, and it will require some actions to bring mental health into the places where people already use and trust, shifting resources from isolated institutions to general hospitals, community mental health teams, and primary health care, and creating person-centered integrated pathways with clear shared plan, referral routes, and coordinated information from the prevention through specialist support. And one more point, mental health needs span across the life course, and we must ensure that services are equitable, culturally competent, and appropriate for ages and backgrounds. I think that everyone is, you have seen this line maybe in many occasions, but I think that everyone can agree that primary care is central to a holistic approach to health and well-being. And this idea stood the test of the time for nearly 5 decades and relevant, even more relevant now. And echoing the Professor Leonis's messages, we need to shift our perspective and to recognize how broader determinants shape outcomes and to embrace biopsychosocial dimensions of care to have better outcomes for people in the need of care. To help the countries to address the rising burden of the mental health care, drawing on the available evidence and best practice examples, we published a policy paper that outlines 4 strategies for aligning mental health services within the primary care approach, which brings together integrated provision of services, community, as well as other sectors for delivery of comprehensive efforts. The first 2 strategies that we proposed are aimed on strengthening capacity of mental health services in primary healthcare setting, either by introducing or enhancing mental health competencies of the existing primary care workers, or expanding the team through integration of dedicated mental health workers. And 2 other strategies, 3 and 4, they focus on strengthening linkages within the health sector as well as between the health sectors and other sectors. And we heard how important it is to have these collective actions. The first strategy is dedicated to fostering mental health competences of primary healthcare providers. And it champions the sustained education and training, enabling the professionals to implement foundational mental health interventions, as well as guide individuals towards self-care and available resources. And the development of such competences is vital for early identification and management of mental health conditions, setting the scene for effective treatment and care. And I think that many of you are familiar with the MHGAP program, which offers such capacity building opportunity. Please join us tomorrow to hear more how countries implemented the program and what lessons they learned along the way. The second strategy calls for adopting multidisciplinary approach and expanding primary healthcare teams through integration of dedicated health workers with competencies in mental health. It advocates for inclusion of other professionals such as clinicians, clinical psychologists, psychiatric nurses, non-specialist counselors, and very important, peer support workers with lived experience to shape the fabric of primary healthcare teams. This integration promises to expand the spectrum and the competence of mental health service available, ensuring that model of care comprehensively encapsulates both the mental and physical aspects of health. Anna, over to you.
Thank you, Sophia, for highlighting those 2 first strategies. And as Sophia mentioned, they are not operating alone. These 4 strategies, actually, you will see some multiple links between them and how important it is that we don't launch along one of them, but actually we work to make them all 4 together and to strengthen that services and access within the primary healthcare. So the third strategy, which is around improving the linkages between primary care and specialist mental health settings, probably is one of the most practical and impactful things we can do to strengthen mental health in primary health care, and it's that it doesn't operate in isolation. It's incredible, essential, and important that this connection between primary care providers and specialist mental health services it needs to happen, because if not, is where usually people fall through the cracks. So the clear referral pathways are a foundation of it. When they are systematic and explicit, we reduce uncertainty and we ensure that people get the right level of care at the right time. Collaborative care models take these steps even further, rather than primary care and specialist services operating as 2 separate wards. Integrated approaches brings providers together, sharing responsibility, sharing information, and making joint decisions about care. Regular communication and feedback to maintain continuity and build provider confidence, but also the user's confidence. And of course, we included another essential point, that is the joint supervision and training to develop the shared language and those relationships that make the real collaboration possible. So when these elements are in place, the system starts to feel that it's joined up and users experience the difference. Next slide, please. And the 4th strategy that we have highlighted on the policy paper is promoting the linkages across sectors to deliver mental health services. So mental health cannot be delivered by the health sector alone. We will hear it multiple times. And we have made we will do it in different points of this mini conference because it sits in a much broader ecosystems, one that includes the community services, one that includes rehabilitation, social welfare, housing, education, labor, and beyond. So this diagram that you see actually makes this visible. The person is at the center, surrounded by the different levels of care and support. So recognizing primary health care as part of this wider ecosystem of mental health providers, rather than one system alone, is fundamental in how we switch, how we think about care delivery. So the competencies across sectors are powerful: housing, employment, education, food security. So these are not only peripheral to mental health, these are determinants of it, as Professor Leonis was highlighting in the previous presentation. So when sectors work together rather than in parallel, the impact is far greater than any single intervention. And finally, joint assessment change who we see. So when mental health is assessed through a multi-sectoral lens, or definition of vulnerability changes, and we reach people who will otherwise remain invisible to the health system alone. Next slide, please. Scaling up mental health in primary healthcare requires putting some key policy levers simultaneously. Once again, none of them works in isolation. So the regulatory frameworks set the direction. Without the right strategies, policy, and multi-stakeholder collaboration in place, all these efforts to reduce stigma and improve literacy, well, everything will fall apart. Financing must follow people and not only facilities. One of the most transformative shifts is reorienting these funds flows away from hospitals and institutions towards more community and primary care settings. We will have a session specifically discussing on this. Workforce is a non-negotiable, so it's true that the numbers matter, but as well the mix and competency of that workforce. Primary care teams need the right balance of skills, manageable workloads, time. Without this, integration remains just a policy commitment that is not consolidated. And finally, the physical and digital environment matters more than we often acknowledge. The purpose-built spaces, the community infrastructure, and investment today as well in digital tools are not a luxury anymore. Next slide, please. And finally, we will also have a session on this, is how important it is to advance digital mental health within primary health care. So digital tools today offer an opportunity across the full mental health care spectrum. And these are not only, they help on reaching unserved population and on reducing long-standing barriers to access. We are seeing evidence growing and growing. These are not marginal gains. When they are deployed well, digital solutions can meaningfully extend the reach of where workforce or primary care and infrastructures fall short. But every opportunity without the right conditions is risk. So safe, ethical, and effective deployment requires four essential things, at least that we are seeing more and more in the consultation with experts and with our member states: governance and frameworks to guide how these tools are selected and used, equity and inclusion to ensure digital solutions don't create even more gaps, data privacy and users' trust, because without trust, we will not be able to use in the good the tool. And finally, something that is essential is the regulation and certification to ensure that what reaches user actually works and do not do harm. So the bottom line here is clear: digital tools are system enablers, not standalone solutions. So they need consistent governance, clear evidence, standards, and intentional integration pathways to deliver what they're supposed to be delivering and what they have promised. So safely, equitable, and effectively interventions. And with this, we finalize the showing you these four strategies, the different policy levers to be able to scale up mental health and in primary health care, but also these new advantages and these opportunities we see within digital tools that can be used to enable more even access to care. Thank you, everyone. Thank you very much, and I hope you continue enjoying this mini conference.
Thank you very much, dear Zofia and dear Ana Maria. You set the stage very nicely for the rest of the mini conference to go into much more detail of the 4 key strategies to scale up mental health services, and also to discuss and debate the important enablers. And now I would like to bring these 4 strategies to life with an interesting panel discussion, potentially a panel debate. I will be joined by 4 panelists who represent different perspectives, people's perspective, practice perspective, and I would really like to discuss with them these 4 strategies. I will be introducing them as I'm bringing into the conversation. Thank you so much for joining us. I'm also now speaking to you, our dear audience. You have been so active in the chat. Keep it up. But now it's really time to reflect on what you're hearing. Share your perspectives, ask your questions, and Lydia and I will try to summarize it from time to time and bring it as well to our speakers. And with that, I would like to go to our first speaker, Arnaud Poitevin, Deputy Director of Esper Pro, which is an NGO operating a platform of recruitment support for peer support workers in mental health from France. Arnaud, thank you so very much for joining us. And I really like that we're starting this panel with you, because you're going to bring the perspective of the people. Again, you represent a service user organization, and your insights are really invaluable for shaping services. The question to you is, we have discussed the life course perspective, that mental health issues at the different stages of the life course can be quite different. With the different transitions that people go through, how do you think mental health care can be brought closer to the people, or be designed closer to people? Over to you.
Thank you for inviting me, introducing me. So I'm Arnaud Poitevin. I work for a peer support workers platform. So maybe I just explain what is a peer support worker a little bit more. We are people with lived experience supporting other people with lived experience of a mental health condition. And so we are we are accompanying people with these with conditions. Yes, as you said, thank you, Melita. I will carry the voice of people with lived experience during this intervention. I want to stress the fact that it's important when you are a medical professional, family doctor, and so on, to adopt, feel, and understand genuinely the experience of the patient, and to stress also the importance of hope, treatment, and support exists. So it's important when you are a practitioner to put forward these realities. I want to say also that when you're a practitioner, it's important to focus on strengths of people's, not only on failures, deficiencies, and only on diagnosis. I think, again, as it was said before, that there is a strong need for psychosocial approach of mental health, taking in consideration the personal environment. So walking, fighting isolation, finding balance in one's life project is as important as treatments. Treatments are important, but they are only a fragment of the solution. So poverty, social isolation, stigma, unemployment, education are also very important. So I would like to stress the fact that it's important to understand the power of peer support and co-construction, involve people with lived experience of a mental health condition in whatever project you set up regarding mental health activities. So it can be as important to speak about informal peer support through, for example, self-help groups, as much as professional peer support. So this peer support improves the recovery level of people. So it's important to stress this fact. Also, it's important when we talk about scaling up mental health in primary health care, to speak about having the big picture. So it's already been said before. So there is a lack of liaison and interconnection. So it's important to coordinate the various operations of professionals. and have a global approach when we speak about people, and a case management approach, so that we have the full picture of the patient's journey. I would like to speak about perceptions also, so please interrupt me if I'm too long. I would like to speak about perception. Stigma is an important issue, so it shouldn't be a shame to talk about emotions, mental health treatments, and psychiatric support when you reach out to a general practitioner. There is a a clear lack of mental health literacy, and health rights literacy that should be addressed. I stress again the importance of the cultural determinants also of mental health that should be addressed, and have a culturally competent care and trauma-informed care. And a care that is designed for dealing with all stages of all age stages. So as much children than adolescents, than young adults, and than older adults. And also, maybe last but not least, a patient should not just be patient. So I would say that it's important to make sure that care is the front door of primary care is open, but the referral door is not locked. And so it's important also to fight this issue that services communicate on their existence even though they have a low budget or overwhelmed or are overwhelmed, and there is a lack of visibility of community mental health services, services in the community, and for example, self-help groups are usually not as known as they should. So this kind of support should be more known by all professionals. Thank you.
Thank you, Arno, for bringing us the perspective of persons with lived experience. And I want to also use this moment to inform the audience that you have been a champion for integrating lived experience in mental health policies and services, to the point that last year, high-level conference on mental health in all policies had more than 10% of its participation representing lived experience, and you played a very crucial role into that. So thank you again. I have now the pleasure to introduce a member of the WHO Youth Advisory Group for Quality of Care Mental Health Services. This is Katerina Sidirolu. Dear Katerina, we know that children and youth mental health problems are an important global public health concern. Primary mental health care services can play a very important role, but we want them to be friendly to young people. So we want young people to relate to the services. And because one of the reasons, as we heard at the beginning, that we want mental health to be integrated into primary health care is also as a way to address stigma and discrimination in mental health. So would the young people see mental health integrated at the primary care level? So would they see primary health care services accessible, youth-friendly, and trustworthy?
Dear Lazeri, thank you for having me, and thanks for this important question. It's truly encouraging and optimistic that among so many selected panelists, there is also space for the voices of young people. So before answering your question, I think it's important to repeat that primary health care is crucial for scaling up mental health services. Primary health care is where prevention can happen, is where early intervention can happen. It is where stigma can be reduced by normalizing that mental health is part of the overall health. And when it functions well, it can connect young people with the level of support they need before challenges escalate into crisis. However, I would also like to gently challenge the current reality. While primary care is technically available, many of us do not perceive it as truly accessible, youth-friendly, or trustworthy for mental health concerns. And perception matters because if we don't feel safe walking through the door, the system has already lost us. So one of the main reasons this happen is because of awareness, lack of awareness. Many young people simply don't associate general practitioners with mental health. We grow up thinking that general practitioners treat physical problems, not anxiety, burnout, or depression. So when emotional difficulties appear, primary care is often not the first place we think of. But even if we do, several barriers exist. Appointments feel rushed, our experience quickly summarized into assumptions. Communication may feel overly clinical or adult-oriented. The environment itself can feel exposing, especially in small or rural communities like the one I come from, where privacy concerns and stigma are greater. And this brings another important topic, confidentiality. And confidentiality is a major issue. Young people frequently ask, will my parents be informed? Is what I say really private? If these are not explained from the beginning, trust erodes immediately. And there is also among us the experience of not being taken seriously. Symptoms usually dismissed as just stress or is a phase. And when that happens, we are much less likely to return, and it reinforces the belief of that we should handle our problems alone. And of course, there are also structural barriers, long waiting times for referrals, limited access to psychological therapies, over-reliance on medication, inconvenient appointment hours that conflict with school or university, and the lack of trained professionals within primary healthcare teams. However, the stronger theme I hear from peers and what emerges from the above is trust at every stage. Trust to disclose honestly, trust to be heard and taken seriously, and trust not to be dismissed and received appropriate follow-up. So yes, primary care may be the first point of contact on paper, but as it is now, without reforms, young people will continue to seek support elsewhere, through peers, online, and in the worst case, not at all.
Thank you very much, dear Katerina, for this very honest and frank reflection. And also thank you so much for reaching out to your peers and bring their perspectives to the table. I think with your narrative, we can now really get going, right? And dig deep into what aspects of our service delivery models are not fit for purpose for young people, but there are also other population groups that may experience similar challenges or different challenges. Particularly, I'm thinking about older people or people who have certain socioeconomic disadvantages as well. So that's very, very helpful. With that, I'd like to come to you, Catherine, and I would like to introduce to everybody Dr. Catherine Rouleau, who's a practicing GP, but she's also the Global Primary Healthcare Lead at the Department of Family and Community Medicine at the University of Toronto in Canada. And Catherine was one of the chief editors of the primer on primary healthcare we published a couple of years ago, where you can look at everything from A to Z on primary healthcare policy and practice. And we work very, very closely. But today, Catherine, I would like you to wear first your GP hat, right? And I would like you to bring us the realities of your daily practice, of what you think about these 4 strategies, which ones are you applying, how you think about this whole issue of serving your population better with mental health services. And adding to Katarina's narrative, the chat is also very vibrant. People are talking about how to integrate with specialists. Is it something you're doing and working on? How to reach people who are distant or really far away? Are we using telehealth and telemedicine services? Over to you.
Thank you so much, Melita, and thank you for the invitation to join this really dynamic and knowledgeable and stimulating panel. So I like to say that my day job, my core identity is actually to deliver comprehensive primary care in the family medicine model at St. Michael's Hospital, which is an environment. So I am not situated inside a hospital. I work in a community where the majority of the people who live in the neighborhood where I practice are actually subject to fairly significant adverse social determinants of health. So a lot of poverty, a lot of newcomers. And I've been in this community as a practicing family physician for over 30 years. And so my take on a lot of what I hear is that every visit is a mental health visit. And if we agree that we are to practice and approach primary care in a biopsychosocial model, then it stands to reason that everybody who crosses the door has biological issues, psychological and social issues, and they all present mixed in together. And so sometimes, as we say to our learners, sometimes the mental health issue enters the room first, and sometimes it's mental illness. I'm depressed, I'm anxious, I can't sleep. I'd like to put my spouse out with the recycling, all the versions thereof. But sometimes, and most of the time, the mental health issue may enter the room second. And so the 35-year-old father of 4 who comes in with a knee injury after playing soccer for the first time in 4 years might present with the knee pain and concern about being able to play again. But in the back of that often are all kinds of other mental health related issues about self-identity, about function, about how to function in the social sphere, about work, about all of this. And similarly, as you've mentioned, Melita, across the life course, we see these mental health issues present in slightly different colors, slightly different ways. The teenager, we've talked a lot about teenagers. I happen to be the mother of now a late teen, but still a teen. It's very rare that the teenagers come into the office saying, I have a mental health issue I'd like to discuss with you. It comes in the under, school is more difficult, relationships is more difficult. In the elderly, the memory is going, I can't remember anything. And there are, so the signs are different. And so what I'd like to say about this, in my practice, and I heard this, from Professor Leonis, I heard it from Viviana, I heard it from our patient advocates and partners. One of the key things is to recognize it. And so to actually, before we recognize it, to be tuned in, to understand, to sort of be receptive and to be in a stance where we can actually receive it, which is not always easy, depending on how quickly you need to go through patients, and we'll come back to that. So first, to be open to it, to recognize it. Second, to know, to name it, and to name it with the patient. And that, I have to say, the crucial part here is the continuity in the relationship. It's very difficult in the first visit with a patient to say, I think you might be depressed, or could this be anxiety? This is not the way that usually works well. You need to sort of invite it, and Katerina was so good at describing this. You need to open the door for the patient, the person who is in front of you, to actually be able to unpack this with you. It's almost impossible without a good relationship and continuity, which means that when we think about primary care and the way we deliver it, we need to allow for relationship building and continuity. And there are many ways to do this. We can come back to this. And then the third is what people have said. There needs to be competence in knowing what to do with these problems. So it doesn't matter if I'm the most compassionate, empathetic, best listener in the world. If I don't know what to do with the problem, if I don't know all of the modalities and the complex modalities that are needed to actually address mental health issues, I'm no good. And I would say in primary care and in comprehensive primary care, yes to referral, but before referral, I need to be able to address most of this in my setting within my team. And so those, I'm going to stop here. I know we'll come back later to the how in this panel, but maybe I'll stop here and actually I'll say one more thing. One more thing is the social determinants of health. And so we need, there's an issue of language, there's an issue of subculture, there's an issue of all of these things, which also come into play with the recognition and the offering of the solutions. So the solutions will vary depending on who is in front of us. And now I'm going to hand it back over to you, Melita, aware of the time.
Thank you, Catherine. I'm taking over with expressing my wish for you to become my general practitioner. I would love to sign up in your clinic, looking at the passion and how structured you are into looking at the person very comprehensively. But we can take that aside, me signing up for your practice. I'm now going to my dear colleague, Professor Ronnie Brufert, who is a founding member of the Pan-European Mental Health Coalition almost 5 years ago in Brussels. And Ronnie, you are both representing a country that has for the last few years been recognized as a leader in transforming its mental health services through a comprehensive mental health reform, but you are also an academic and a researcher. And as an academic, as a researcher, my question to you is, what was the evidence that prompted your country, Belgium, to informed its transformative mental health policies?
Thank you, Lydia. It's a good question. Good morning, good afternoon, good evening to all. I think if I look at the past 15 to 20 years of mental health care reforms in Belgium, I see, in my opinion, four main drivers or four main areas of evidence. It's been stated before, the historical argument of having lots of psychiatric beds that created a hospitalized or hospitalization-focused care above outpatient care, treatment above prevention, but also led to large overmet needs and the lack of any integration of services. So the first element that really was important is to say that what we have disorder and diagnostics driven and based inpatient facility system, and that contradicts the attention that has been issued or published in 1989 in Belgium to say we have to reduce the number of beds. So it took much longer than intended, but it's been an intention that was there for a long time. The second one is that we've seen over the past 20, 25 years, maybe 30 years, a vast increase in the demand for services. And we've seen that increase in primary care. We've seen that increase in emergency rooms. And we've seen that increase in ways that people that are not exactly mental health related. And so it popped the question and it gave rise to the question, is a mere increase of the number of psychiatric beds, is it capable of solving that problem of demand that increases significantly? After all, there's a lot of primary care physicians, there's a lot of primary care actors that could be integrated in that system of mental health care provision in the community. I think a third driver, and now I speak more as an academic, the third driver is that we have data, or we provided in a systematic way data instead of opinions. And I'm just referring to WHO, the World Mental Health Surveys. We ran 25 years ago, more than 25 years ago, the first community surveys in Europe and also Belgium that clearly documented the prevalence of disorders, but more importantly, that most of the people don't make it to treatment, most of the people don't make it to treatment in time, that the burden on community is enormous. And once people make the treatment, that the quality of the treatment is low to moderate. So these were really evidence-based versus opinion-based elements that were repeatedly addressed to policymakers. And the fourth one is combined. All these four elements are combined, of course, they don't stand alone. But the fourth element that really enabled us to go one step further is that we have a framework, we have a conceptual framework that is kind of a roadmap that guides us through the healthcare reforms. We can discuss on the content later, but the main thing is that reforms and mental care organization have to be aligned along this roadmap we have established in 2010. So it means that every actor, being outpatient or inpatient, is actually forced, is required to collaborate on the care for people with mental health disorders. So mental health care becomes a collaborative effort and a good for all. And so this is one sustainable framework that I think it was crucial to speed up the healthcare reforms, not just in the past 50 years, but I'm convinced also in the next 10 to 15 to 20 years.
Thank you, Ronnie. And I think it's now the moment, exactly because of what you said, to inform the audience. We are very excited to have Ronnie leading a newly designated collaborating center on public psychiatry, because we want to bring that approach, what you said, Ronnie, bringing evidence into policy, making sure that what we know from evidence is feeding policy. And before and stay, because next question is to you, but I want to inform the audience that we are now moving to the second round of questions. And the second round of questions is about how. We heard about the whys, but we need to also learn about the how. And because of the timing issues, I would propose that the next round of questions invites the panelists to respond with shorter questions, like to 1 to 1.5 minutes. I hope we can manage to bring your ideas in a concise way. And then this brings me back to you, Ronnie. You talked about the importance of evidence. And then the question is now, you've been evaluating those investments, particularly around integrating psychologists into primary healthcare, no? What are the outcomes? What do we know? What is working?
I try to explain and discuss in 2 minutes. The main reform in moving mental health care into primary care started actually in 2019. It's a reimbursement framework for mental health consultations in a primary care setting. And it moves away from the classical idea that therapy is being done in the therapist's office. No, we move away the locus of care to primary care and community. We move away focus of care instead of long-term treatments to short-term treatments, maximum 8 sessions. And importantly, we evaluate continuously the health benefits or the health gains on the individual level of the patient, but also on the individual, on the community level for society as a whole. I'm just trying to discuss 2 main or 3 main findings. And the first one is, so far, since its implementation, 600,000 individual patients have been treated. This is equivalent to 5% of the general population of Belgium. So just by looking at the numbers alone of people treated, it shows community impact on the long-term perspective. And in more detail, just two details or two illustrations. The burden of disorders of people treated within that framework reduces by 37%. The number of disorders decreases with 15%. The severity of emotional problems decrease with 20%. And people do not mention stigma as a way of getting into the system. On the community level, and that's the last one, and I think that's the most important finding, is we know that it takes a long time on average before people enter treatment. Normally, it averages like 10 to 12 years before people effectively enter treatment. In primary care psychology in Belgium, it reduced that delay from 10 years to 4 years. So on the community level, that gave us 6 years of health gain on the community level. And so the ways by creating a low threshold step up, easily reachable care, psychological care, psychological sessions that really enables policymakers to establish a long-term sustainable framework for entering mental health. I still have a lot more to discuss, but I'll stick with this. Thank you.
I'm sure, Ronnie, thank you very much. This evidence is so powerful, and we really look forward to working with your collaborating center to take all this evidence and produce this evidence in every country that needs it. Catherine, let me come to you and ask just a simple question for your wrap up. What do primary healthcare practices like yours need to implement better mental health services? What is the how that you need? What are your top three?
So I think there are 3 big buckets of things to pay attention to. The first is the competency of the providers, and I'm actually going to talk about the competency of the physicians. So we're trained in family medicine to address mental health issues, certainly in my country, and yet it takes a different skill set. It's not just the knowledge. The providers need there's an emotional intelligence, there's an openness, there's issues of addressing your guilt and shame and your own baggage in order to be able to receive and enter in that relationship. So I think there's a whole issue of, I'm going to say, training and transformation of the health workforce that needs to happen. I think then there's the architecture of the actual team. And, we've heard many times a doctor alone cannot do this and often should not do this. There are other members of the team that are sometimes better as entry points. And so who are these people? In my setting, we involve social prescribers, we involve community health workers, we have a health promoter whose job is actually to look at the finances of the patients with them and make sure that they avail themselves of the programs available. There are psychologists, there are various therapists, there are addiction workers, etc. So you need to have the right team within primary care. And then the system needs to allow you to have the pathways that we talked about and the space to do it. So I can connect to some psychiatrists. We have a concurrent care model in my practice. I have psychiatrists on my cell phone, not for a long consultation, but I've tried these 3 medications. There's all these side effects. I don't know where to go next. What do I do? There are pathways that allow that kind of architecture and quick space and movement of patients and knowledge so that you can actually provide care in a timely way. There are many versions of those, and I could keep going, but maybe I'll stop here for now in the interest of time. Over to you.
Thank you, Catherine. And this brings us now to Katerina. I would love to hear from you, Katerina. What concrete changes would you recommend to make the services more responsive to the unique needs of adolescents and young adults as well? And what would help for young people to feel comfortable and empowered to seek mental health support in primary care settings?
Well, thank you. If I had to summarize the how from a youth perspective, I would say this. We don't just need more services. We need services that will be designed for us, with us. And I would highlight 4 concrete priorities. First, build awareness and change the narrative. Many young people still don't know that primary care is a place for mental health support. So we need targeted campaigns in schools, universities, youth centers, and on social media. We also need clear accessible information. What happens if you disclose a mental health concern? What does confidentiality actually mean? What are your rights? Clarity reduces fear, and when fear decreases, help seeking increases. Second, make primary care youth-friendly. Accessibility is not just about location, it's about design. flexible appointment hours, easy online booking, telehealth options, and where possible, youth-dedicated spaces or consultation times. Guarantee longer appointments for mental health discussion. If an appointment is rushed, young people won't open up. Confidentiality should always be explained clearly at the beginning of the consultation. And all the small changes in communication, such as empathy, non-judgmental language, shared decision making, can completely change whether a young person comes back or not. Third, let's try to address system-level barriers. Primary care professionals are often overstretched. If we want to deliver quality mental health care support, they need support themselves. So structured training in youth mental health, increased staffing to reduce rushed care, clear referral pathways with shorter waiting times, proactive screening, not waiting until the crisis comes, and where possible, integrate psychologists, youth workers, or trained peer supporters in the primary care systems. Sometimes speaking to someone who feels relatable makes the first step less overwhelming. And I would like to say that when a young person gathers the courage to seek help, the system should respond quickly and coherently and not send them into fragmented waiting lists. And finally, and most importantly, if I had to choose one priority, it would be this: co-design services with us at every level, from physical spaces and materials to policies and training. So please gather our thoughts through youth advisory groups, workshop, or digital input to shape the system that are supposed to be there for us. And when young people see their input reflected in services, the trust increases and engagement increases and the ownership increases. And last but not least, primary care is already close to our homes. Now it must become closer to our realities.
Thank you very much, Katerina. Many of your thoughts are really echoed in the chat, which is very, very rich, especially around non-stigmatizing language and not necessarily making mental health an illness. So those were very powerful. And I think your participatory design will be a very good segue to go to Arno. Arno, you got to open our panel, you get to close our panel, and please bring us back again to the perspective of people. Over to you.
Thank you for this privilege of opening and closing. So I would say the more trust with the professional, the better, as it has been said. The sooner support, the better. I would maybe just stress a few points. Support self-help groups, online or physical self-help groups. So in France, we have hundreds of groups supported by government agencies. So it has been shown efficient to fight isolation and supporting empowerment and citizenship. And it's better than to be left alone in the waiting list somewhere. Recruit peer support workers with a dedicated training for them and their team on person-centered care and recovery-oriented practices. The mental health training part is also an important aspect. So GPs, mental health professional, primary health care professionals should be trained in their basic academic training to mental health, and with including peer support worker or people with lived experience in the training as a must. It's important to communicate on existing treatments and psychosocial support, again, psychosocial support in the community. Important again also to reach out to people with mobile units, outpatient treatment, use of social networks. Include carers also on the support strategy as much as possible. And again, fight stigma. As you may know, stigma entails 20 years less of life expectancy. So it's important to explore cultural representations about mental health, pop culture, movie, musical industry, and so on. Set set up attend events such as living libraries, which are quite a powerful tool to fight stigma, and also share information and spread myth busting through evidence-based data. So people with a mental health condition are not more lazy, they are not more violent, and this should be widely known to all everybody, everyone. Thank you.
Thank you very much for these interventions. And I think you set up the next session so well for this conference about the model of care and various innovative ways to structure models of primary healthcare to scale up mental health services. I want to thank all our panelists for their fantastic job. So wherever you are, put your hands together for our panelists. You have given us a lot of inspiration and a lot of thoughts to take into the following sessions, both today and tomorrow, for further unpacking. To our audience, you have been wonderfully active. We tried to bring in some of your perspective into this panel discussion, but I recognize we didn't get to all of them. We're going to pop it into a summary later this afternoon. We will feed it to the moderators of the following sessions to make sure that all of them will be answered. We take a short health break right now. It will be a 9-minute health break, and we will start the next session at 12:45 sharp in CET time zone to strengthen the model of care with great moderators, presentations, and a lot of country examples. Thank you so much, everybody, and see you in 9 minutes.
Thank you so much, Rachel. Good morning, good afternoon, and good evening, everyone, and a very warm welcome to the first technical deep dive of this conference, which focuses on transforming the primary healthcare model of care to better address mental health needs. I cannot see the slide. If we could advance the slide, please. I'll just carry on while we're waiting for the slides. My name is Anna Sagan, and I'm a technical officer at the WHO European Center for Primary Healthcare in Almaty, Kazakhstan. I have the great pleasure of co-moderating this session with my colleagues, Professor Jan de Massenier from the WHO Collaborating Center for Family Medicine at the Ghent University, and my colleague Rachel Greenlee, who is Research Fellow in Global Mental Health at the London School of Hygiene and Tropical Medicine. Rachel, we cannot see the slideshow mode. We seeing your moderator's version. Perhaps you would like to adjust, but we can move on to the next slide. Our session is structured. Oh, perfect. Next slide, please. This is us. Our session is structured in 2 segments, each lasting just over 1 hour. First, we will explore how to better identify mental health needs in communities, especially needs that are often under-recognized or hidden. And secondly, we will look at strategies to strengthen the management of mental health conditions in primary care and in the primary healthcare approach more broadly. Each segment will include a keynote to frame the main issues, a country panel where some practical examples will be shared, and also some time for questions and reflections from the audience. There will be a short 5-minute comfort break in between the 2 segments. Next slide, please. Thanks so much. In the country panels, we will hear from Dr. Johanna Creswell-Smith, who is Senior Specialist at the Finnish Institute for Health and Welfare, from Dr. Edita Bishop, who is Advisor in the Mental Health Division of the Ministry of Health of Lithuania, from Dr. Goran Cherkes, who is Assistant Minister for Public Health at the Federal Ministry of Health of the Federation of Bosnia and Herzegovina, and from Dr. Aida Spahic, who is Senior Advisor at the same ministry, and finally from Dr. Francisco González Aguado, who is Deputy Director in the Office of the Commissioner for Mental Health at the Ministry of Health of Spain. Next slide, please. A few housekeeping announcements before we move on. In the chat, our colleagues will repost instructions on interpretation, asking questions and viewing the presentation in your preferred language. I believe I was looking at the Russian channel and not seeing the slides moving forward. Sorry, Rachel. Please use the Q&A function in the chat for your questions and reflections. Let me now hand over to my colleague Jan, who will lead the first segment on identifying needs and reaching hidden populations. Jan, over to you.
Thank you very much, Anna, for this opportunity and for this introduction. As mental health needs continue to rise, of course, it's important to improve detection and identification. And in the previous session, a lot of good examples have been given, and also emphasis was put on the importance of the context, the socioeconomic, cultural, and environmental conditions. And Professor Christos Leonis, in his wonderful contribution this morning, stressed the importance of all these determinants. And I think that one thing that we can add to that is that we, apart from the psychological, the biological, and the sociological lens, we also need continuously the ecological lens, because climate change, air pollution, and lack of green spaces are contributing to anxiety, to depression, and cognitive decline. So the evidence is there. Natural disasters and extreme weather increase stress and trauma, while exposure to green spaces supports mental well-being. So that is very important that we also use that lens. Of course, sociologically, we know that the risk of people in poverty for mental health, that is a huge and probably the most important sociological determinant of mental health. When it comes to biological determinants, of course, multimorbidity and disabilities are also determinants of mental health. Next slide. As Professor Leonis also said, a focus on life course approach in practice is very important. So we have to try to find out what really happens during a life course. But what we often see is that in mental health there are too many labels, and it is not always easy to use them appropriately. And those labels are often working as double-edged swords that can lead to stigma, to identity issues, and to over-medicalization of normal emotions. So I think always when we talk about mental health, words matter, and especially in mental health, I think we should use words and labels very carefully. Next slide. Of course, how can we find out the hidden populations? Well, I think the essence of this is that we use the appropriate lens, because you cannot see the things that you want to see if you don't use the appropriate lens to really have a good view. And I will pick up some of the things that during my 40 years as family doctor in the community I've been confronted with. The first one is gender diversity. Gender diverse individuals face significantly higher risk of mental health challenges, including anxiety, depression, and suicidality. This is largely driven by societal stigma, discrimination, and lack of support. These challenges are rooted in minority stress rather than in intrinsic factors, with risks exacerbated for youth and those experiencing low social support. And this has been documented in England, where there is absolutely gender-related inequalities documented in this study, certainly based on self-reported mental health outcomes in England, and that aspect comes up very clearly in that kind of research. So better healthcare system inclusivity and healthcare professional training are needed alongside broader improvements in the social and legal environment for transgender, non-binary, and gender diverse people. Another important group is loneliness. Loneliness is a significant mental health risk associated with increased rates of depression, anxiety, low self-esteem, and sleep problems. It often creates a self-reinforcing cycle in which feelings of isolation lead to social withdrawal and vice versa. For young people, and we heard it already, exclusion and isolation in the context of social media use may contribute to digital loneliness with negative mental health impacts. Next slide. Other hidden groups, and when we look, we will see them clearly, are migrants, refugees, and asylum seekers. They all experience higher rates of depression, anxiety, and post-traumatic stress disorder compared with the host populations. These risks are often driven by pre-migration trauma, by dangerous journeys, and post-migration stressors such as insecurity, social isolation, and discriminations. People from ethnocultural minorities often face health disparities linked to higher risks of psychological stress, stigma, and systemic barriers to care. Effective care requires addressing cultural stigma, overcoming language barriers, and providing cultural-sensitive treatment. In a recent PhD work realized by a clinical psychologist from African origin under the title White Care, Black Suffering, it became very clear that mental health care remains largely aligned with the norms, diagnostic frameworks, and lived experiences of white individuals. So it is important that we have to look how racism affects mental health, how it permeates mental health care systems, and how it can be addressed. Next slide. Another very vulnerable population are people in prison. Studies indicate that roughly 55% of incarcerated individuals in Europe experience mental health issues, including depression, PTSD, and substance use disorders. These conditions are often worsened by the prison environment, which is characterized by high stress, overcrowding, and very often inadequate mental health care. Another important group are the homeless people. Roughly 60 to 70% of the unhoused individuals experience mental health disorders. Mental illness often precedes homelessness, while the trauma of lacking shelter can worsen conditions such as depression, anxiety, PTSD, and substance use disorders, creating a vicious circle. In Ghent, we were involved in a project where we have looked at what was the situation for homeless people. We interviewed them in shelters, and we found that in Ghent, most of the homeless people had an access to primary health care and made use of it. And probably the universal primary healthcare system in Ghent, with low threshold and with an active guidance by social workers, contributed to the fact that those homeless people had GP access and also could address primary care psychologists, which probably also had an impact on the fact that in our city we see a lower number of homeless people addressing the emergency department of the hospital. Next slide. And then also, evidently, we have to look at actually the broader context. Nowadays, all citizens, I think, are influenced by geopolitical uncertainties. The recent Eurobarometer from the 13th of February, 10 days ago, very clearly illustrated that more than 2/3 of the Europeans, 68%, believe their country is under threat. Member states with the highest perception of are France, 80%, followed by Netherlands and Denmark, 77%, and Cyprus and Germany, 75%. At the same time, 42% of the citizens believe their personal safety is at risk. And of course, this also influences mental health. Let us not forget, and the evidence is huge, that peace is an important factor for good mental health. And so that also has an influence, and we see it in our daily practice when we meet patients. Next slide. Identifying mental health needs should be done in our primary healthcare perspective, and it was already by Catherine referred to the primer on implementing the primary healthcare approach. And of course, multi-sectoral policy and action, empowerment of people and communities, and also working together in integrated health services are very important. Integration between primary care, social care, public health, and specialist services is of utmost importance, and already many examples were given in the previous session. Destigmatization campaigns and outreach are important, and interprofessional integration of the information is also a very important point. A lot of information is available, but is not at the right place with the right provider and the right patient at the right moment. In Belgium, we try now to contribute to a Belgian integrated health record, and also other countries are on that pathway. Of course, when it comes to mental health, carefully taking into account privacy issues. It was mentioned already that these are very important. Of course, we will have to focus on empowerment of individuals and intersectoral action. Importantly, also next slide, is that we try to use a proportionate universalism. That means that we are going to address people with greater intensity of action is needed for those in greater socio-economic disadvantage. But we will do that in a universal way, not only looking at the most disadvantages, because that will not reduce the health gradient and will only tackle a small part of the problem. Importance also of trust. It has been mentioned already many times in this talk and in the previous contributions. And now we have very clear data. It's documented in an excellent OECD report, Does Healthcare Deliver? And you see here the illustration that people who rate their healthcare better are consistently more inclined, rate their health better, are consistently more inclined to also trust in the healthcare system and the healthcare providers. And I think that's very important. This element of trust should be stressed. By the way, also this study illustrated that respondents tend to trust the health systems more when they have received high quality primary care. So primary care experiences are very important also in the mental health field. Trust in health systems goes hand in hand with trust in national governments and general trust. The key lessons in conclusion are that effective approaches need to be comprehensive, focusing on well-being, not only illness, by addressing social ecological context, proactive, not predominantly reactive, PHC anchored with integrated care and relational continuity across the course to build trust, guided by proportionate universalism. And finally, community-oriented approach, strengthening mental health promotion, outreach and support is important. And next slide. Just an example from the community where I've been working for 40 years as a family physician, and where we started after the COVID an initiative to bring people together and to build with the local population a consolation spot, engaging in a process with the community to address mental health issues like mourning because of loss, and we lost a lot of people during the COVID. This is an important process. This project was supported by the regional government of Flanders, and we work bottom up with the community. It's not a medical service, it's not a psychological service, it's a place where people can meet. They organize the place, they reconstruct it within the park, meeting places for individual encounters with small groups, but also for broader initiatives where they can learn from each other's experiences. Recently, there was a person there that lost a child due to suicide, or lost a partner due to cancer, who had to cope with depression, had a difficult family history. This kind of interactions, bottom up informally, creates really a community mental health climate. And I think that this is very important. It's an ongoing journey organized by the people, creating opportunities for consolation, for building social cohesion and connectedness, and to strengthen resilience and solidarity. Thank you.
Thank you, Jan. That was a really important framing for our session. And many thanks for highlighting a lot of the vulnerabilities and the different areas of intersection toward, those who are often overlooked. So before our country panel, I'd just like to hear from the audience. And so we've set up a Slido poll. So hoping that everyone can see this now, but we've got a poll on the screen here. And so if you're able to use your camera, we're hoping to get some ideas around what you feel are the biggest barriers to identifying mental health needs in primary care. So Jan has mentioned a few, particularly around populations, but we're wanting to hear from you. So if you're able to scan from your phone, or you can type in the link here at the bottom. We've just got a few minutes, but what we'll do is we'll ensure to come back to this after we speak on the country panel. So please scan the QR code or use the link in the chat. And we've got about 60 seconds, so we'll come back to this after. I'll give you a few more seconds. And I see that there's been some engagement in the chat, which is really nice to see. I believe we've got a few questions coming in, but please don't hesitate to type in your questions as we go. We'll have lots of time shortly to be able to answer them. I think we need to share the link for the QR code in the chat, which we can do. We'll have a comfort break as well. So maybe in the meantime, we can move on to our country panel. So Anna, I'll turn it back to you.
Thank you very much. In this first country panel session, we will look more closely at 4 countries and explore the different strategies that they have implemented to identify mental health needs early and reach to people most in need. Let's start with Finland. Johanna, could you share how Finland has strengthened primary care and well-being services to lower the threshold for access and support earlier identification of mental health needs?
Thank you very much. Can you hear me?
Yes, perfect.
Excellent. I believe you're going to look after my slides. So if we can move on with the slides. There we go. So thank you very much for inviting me. My name's Johanna Grosol-Smith, and I'm from the Finnish Institute for Health and Welfare. We're a research and development institute, so that's predominantly where my talk is coming from today. Next slide. So I thought I would begin with outlining Finland's primary care system a little bit before this. And like I said, the main focus of this talk will be, or the actions I'll be bringing up relate to governance, which is of course part of the report that we're discussing, what we're following up, and what was discussed a lot in the first session already. But later on, I'll be also talking about more service-orientated adaptations that we've done here in Finland. So Finland has a fairly long history of universal healthcare in different formats. And importantly, we've undergone recently a very large health and social care reform since 2023. It was already planned many, many years ago. And a big part of that was shifting responsibility from over 300 municipalities to 21 what we call well-being service counties, plus then the city of Helsinki, who arranges their own services independently. So we were shifting from a sort of decentralized system to a more centralized one. And the aim of this reform centered around a lot of the points that the report also echoes, which is about improving quality and effectiveness of services, making sure to integrate these services more effectively throughout the system, providing equitable services for everyone, of course, a very important part. And also this increase in preventative and promotional work, which is kind of my area of expertise, is around mental health promotion in a general level. And also, of course, curbing costs is usually a big part of these reforms. So Finland delivers these universal primary care services through what we call local health and social care centres to all residents. And in addition to this, we're serviced by 5 larger collaborative regions, which coordinate specialist care. And that's usually done around a university hospital. So primary care is the entry point also for mental health services. And we provide mental health and substance abuse support, and more through these low threshold psychosocial models. And one big part of this reform is integrating with different sectors and services. So there's strong integration with child and maternal welfare clinics, schools and student health services, and so on and so forth. Also occupational health. And the reform has been brought together via several different strategies, one being the National Strategy for Mental Health, and we can go on to the next slide now, please, which aims to support mental health of the whole population through very broad actions. So the strategy spans, importantly, 10 years from 2020 to 2030, and is built along 5 main points. An important one here is this top one, which looks at mental health as human capital, and that's recognizing also positive components of mental health and the need for promoting mental health in general as well, throughout the whole population, regardless of mental or other health needs. And then mental health for children and young people, trying to improve services there, and I'll talk to you about that in the next session a little bit. And we also talk about, or the strategy also highlights mental health as a right. So looking at the determinants of mental health, which were discussed also at length in the morning session, things like work and housing and this kind of thing in the center of that kind of point. And then, of course, this appropriate and broad-based mental health services. So really putting the person in the center and developing from there, and also involving people in the service development themselves. And then the last point being mental health management, which is all about placing mental health in all policy areas. So taking a mental health in all policies kind of approach. And in that way, we emphasize that working with mental health should take place within services, of course, like primary care, but also broader within the broader community. And here we're looking at implementing things like the ABC framework for mental health, which looks a little bit deeper at how we can improve our daily lives. And when I say we, I mean for everyone, which is sort of reflecting a sort of dual continuum approach to mental health, which this strategy is very much built on. And importantly, the mental health strategy also includes a suicide prevention program, which offers also opportunities within primary healthcare to prevent suicides and support the capacity of staff there. I think I've had my 5 minutes, so I'll just stop there. Thank you.
Thank you very much to bring us into this context of Finland. And I remember mental health as a human capital approach. I think it's a very important one. Also focusing on well-being, which is in Finland a very important issue, and also mental health as a right. So that implies that you have to address as a country also the upstream causes and the social determinants. Thanks for bringing us into this story. Let's turn now to Lithuania, which has been working from a very different starting point than Finland, including a more hospital-centric model and persistently high suicide rates, unfortunately. Edita, how was Lithuania shifted towards community-based prevention and early identification, including through the role of public health services and primary care? You have the floor.
Thank you, and thank you very much for inviting me to participate in this conference. So for talking about Lithuania, so Lithuania is still undergoing a significant transformation of its mental health system, gradually moving from predominantly hospital-oriented model, as it was as we heard in Belgium, to more community-based system focuses on prevention, early identification, and integrated care. This transformation, can you show the next slide, please? Yeah, this transformation has been driven by the three main pillars. So the strengthening public health function at the municipal level, integrating mental health into the primary care, and reducing structural and stigma-related barriers to access. Public health services now play the central role in community-based prevention, and they operate in almost all municipalities and are responsible for promoting population mental well-being and implementing prevention programs, supporting early identification and in community settings, but I will talk about that a little bit later. And the primary care plays a central role as the main entry point to the system. So the family physicians manage common and mild conditions themselves, for example, like mild depressions. And in recent years, considerable attention has been devoted to the training of the professionals to recognize the symptoms of postnatal depression and to ensure the timely referrals to the mental health specialists. And there are several screening questions which have been put in legislation, which helps family doctors to identify women at risk. So this is one of the examples. And then family physicians identify more serious or complex mental health issues. They refer patients to primary mental health care centers that you can also see on this pyramid. And that's important to mention that the access to these centers is straightforward. So no referrals, official referrals are required. And every clinic providing family doctor services has a formal agreement with mental health care centers, so they could access all the services easily and with no barriers. So basically mental health care centers are the part of the primary care system, but we have a lot of them, so we'll also talk maybe in the second part of the session. But as you see from this pyramid, community-based services form the foundation under this reform, and while more specialized services, including day hospital, psychotherapy, ACT teams, and inpatient treatment, and long-term care, for example, in all hospitals, are available for severe conditions. Next slide. Yeah. So now we'll talk about the public health bureaus. So they are almost in all municipalities, and they play the central role for prevention and promotion of mental health. They provide services in a school, runs public health programs, and monitor population health. As you can see, there is one example like psychological well-being services, which have been introduced about 5 years ago, and they include up to 6 individual psychological consultation. And this was started to break the ice, as we would say, to reduce the stigma and to encourage people to seek psychological help when it's needed, and because of the stigma, quite a people were afraid to visit in mental health care centers. So those 6 individual consultations helps to break the ice and if needed to continue services in the mental health care centers. Also, there's providing group sessions to help develop personal skills in order to strengthen psychological resilience, for example, practical stress management, conflict resolution skills, recognizing the expression emotions, and similar. And the specialists of public health bureaus providing those services, if they notice that the participants needs the more help, so they would refer them to the mental health care centers, the ones I mentioned before. Also, Public Health Bureau provide training programs in the schools, support teachers and staff, and helping them recognize risk factors, respond to issues like bullying or self-harm, and provide effective support. Besides that, we also have in 20 municipalities and Public Health Bureau have a suicide prevention coordinators who facilitate across sectoral prevention, raise awareness, and provide referrals to support needed services. So altogether, this initiative strengthens community-based prevention and early support across Lithuania. And the next slide, please. Yeah. Yes, and this is also very, very important.
Can
because
you take this very shortly?
Yeah, because the stigma was reducing stigma was a key part of Lithuania's mental health strategy. And because a lot of the people were afraid to seek for the help. So we started like the central initiative as a mental health ambassadors program. It was launched in 2023. And the ambassadors are the people with a lived experience who share their stories on topics ranging from depression, psychosis, anxiety, and burnout, grief, and loneliness. And important that we have a lot of the campaigns on the TV as well, where we have famous people like the actors and influencers that talked about the problems, and that's really decreased the stigma quite a lot in Lithuania. As we can see now, with the number of the visits to the primary mental health care centers is increasing a lot. So I will stop here because I could talk and talk and talk, but yeah, thank you.
Thank you very much, Edita, to bring us in this transition, important transition. And for sure, it's a multi-axial and very complex process that should be put in practice carefully. And I think your testimony illustrated the complexity of this very clearly, but also your efforts to make it happen. Let's now go to Bosnia and Herzegovina. Bosnia and Herzegovina offers an example of a system shaped by post-conflict experience and now adapting to changing and emerging needs. Goran, how is Bosnia and Herzegovina using community mental health services linked with primary care to reach vulnerable groups, particularly young people and migrants? You have the floor.
Thank you, Jan, and thank you for your question. Bosnia and Herzegovina is a useful example of how mental health system can be shaped by post-conflict experience and then continue to adapting to the new emerging need. Our post-conflict legacy has created a strong and lasting focus on mental health. Over the years, this helped build recognition that mental health is not just marginal issue, that is central to health, social well-being, and recovery. At the same time, our context is changing, and we are increasingly seeing the new patterns of need, especially among young people, among migrants, and other social vulnerable groups. Even the war has ended, its effects have not disappeared. For many people, trauma can be reactivated by reminders, for example, current conflict in the region or globally, including some existing war or the arrival of refugee. For many people in Bosnia and Herzegovina, those are not abstract new stories. They can be powerful triggers because many of people in our population was displaced, lived through the war, or experience loss and insecurity. At the same time, migrants and refugees arriving in Bosnia and Herzegovina often carry their own trauma that is linked to conflict, dangerous journey, insecurity, or social and economic hardship. Many have had little or no opportunity to recover because before that continue their journey because they stay a short period, which means services need to be to respond to quickly flexibility and example we have today our challenge to respond to the needs of migrants and refugees and to protect the well-being of local population, including children and youth people, whose mental health may also be affected by reactivated trauma and ongoing social stress. Please, next slide. What is important for us is that we don't look at mental health only through the clinical lens. We try to understand it in relation to the person, their environment, and the broader context in which they live. Our community mental health centers, 75 we have in Bosnia and Herzegovina, distributed over the country for both adults and young people, are designed to provide care closer to where people live and to work with other sectors, not only hospitals. These include cooperation with social worker centers, local communities, NGOs. My colleague Aida will explain later how we coordinate all these services and delivering community. But in this segment, I would like to highlight our strong focus across the community on early identification and building resilience. Just a few examples. In school, we run programs that strengthen resilience in both children and teachers, combining preventive education with early child detection of warning signs. Through social center, we engage vulnerable groups, providing targeted support and connect people to services and community networks. At the municipality level, communities develop health profiles to assess the real needs and design coordinated response with all stakeholders in the community, including NGOs. And also we invest in the social environment, for example, through sport, culture, activity, different, more inclusive public spaces that support social connection and well-being of people in the community. To reach the vulnerable group, we also use outreach approach, especially where people are unlikely to come to services on their own. For example, in the context of migrants and refugees, we organize a rapid response outreach through mobile teams from mental health center. These allow also to provide support and in and around the refugee accommodation facility, rather than waiting for people to come to the centers. We also established these counseling points, children-friendly spaces or children's corner, how we call, and direct support of children and families in accommodating facility. One important lesson for us was that people stay only briefly, that contact can be in very short period. What matters that people feel safe, respected, welcomed, and is important this first contact with all migrants and people who need the mental health support. But also arriving in these shelters, it's important this to feel better, to feel like at home. And the last slide, please. Okay,
Very
here
short, please.
You can see here, primary care is essential because it is often the first point of contact, especially when mental health needs to present as a mental health at first. People may come with sleep problems, pain, fatigue, anxiety, family stress, social crises. So the link between primary care and community mental health is very important for early identification, referral, and following continuity of care and reducing stigma, because support can be in family setting, very familiar setting. In practice, this means we need good communication between primary healthcare teams and community mental health services, and clear pathway for when and how people can be supported. This coordination is also important for young people. This is one of the reasons why we develop programs in schools, aim at the building resilience, have already mentioned not only for children but also for teachers. This is very important because teachers are often the adults who first notice change in behavior, functioning, mood, or distress. So in summary, our experience in Bosnia and Herzegovina showed that to reach vulnerable and often hidden population, we need community mental health services, strong primary health care, and coordination across the sector, including social, school, local community, practically all environment where we are living. Thank you.
Thank you very much, Goran, to bring us into that reality and to emphasize the importance to also look at specific groups in your planning within a broader global project for addressing mental health at primary care level. And that brings us, last but not least, to Spain, where primary care plays a strong frontline role and where community resources are more closely linked with health and social support. Paco, how do multidisciplinary primary healthcare teams in Spain help to identify mental health needs early by addressing social vulnerability?
Thank you, Jan, for inviting us. Let me begin by briefly describing how mental health care is organized in Spain. Spain has a universal national health system and primary care service as the main entry point to the system. It's territorially based, widely accessible, and strongly embedded in local communities. This makes primary care a key setting for early detection of mental health problems, longitudinal follow-up, and coordination with both health and social care services. All mental health concerns are initially assessed in primary care. Most common mental health conditions as anxiety, depression, and psychosocial distress are managed at this level. Moderate and severe cases are referred to the specialized mental health network, which is also territorially organized and designed with a community-oriented approach. However, we face important challenges. There is significant workload pressure in primary care, which has increased since COVID-19 pandemic. Social inequalities are widening and demand for mental health support continues to grow. At the same time, we are seeing phenomena such overdiagnosis, overtreatment, and the medicalization of normal life experiences. Quaternary prevention, protecting patients from unnecessary interventions, remains underdeveloped. The inverse care law still operates on collaborative or hybrid mental health models within primary care are not yet fully implemented. Next slide, please. Mental health is profoundly shaped by social determinants. Factors such as poverty, unemployment, job insecurity, housing instability, migration, loneliness, and exposure to violence have a direct and measurable impact of psychological well-being. In primary care, many consultations do not initially present as mental health problems. Instead, we often see physical symptoms, non-specific complaints, or frequent attendance that may conceal underlying psychosocial distress. This requires us to pay close attention to the patient's social and family context. These elements often function as early warning signs. Effective coordination with social services and community resource is essential if we want to provide truly comprehensive care. Primary care clinicians are accustomed to working with uncertainty. In fact, clear diagnosis categories often become more defined at higher levels of specialization. In situations of psychosocial suffering, premature labeling or rigid adherence to protocols may do more harm than good. Working thoughtfully with uncertainty can sometimes be safer and more respectful. Identify social vulnerability is therefore key. When we recognize the determinants that contribute to poor mental health, we are better able to avoid pathologizing social suffering. Our goal is to address the causes of the causes, the underlying needs, rather than focusing exclusively on symptoms. Next slide, please. Another important issue is reaching people who do not actively seek help. Certain groups are frequently underdetected: older adults living alone, migrants, social excluded population, as Jan talked before perfectly. Even when these groups access care, they may encounter barriers that prevent us from fully understanding and addressing their needs. Primary care has a unique advantage here. We function as a privileged observatory of a family of community life because we are territorially based. We are well positioned to collaborate with local authorities, schools, NGOs, and other community organizations. Mapping community assessment at the district level allows us to identify resources that can support patients beyond the clinical setting. Longitudinality, the ongoing relationship over time, is fundamental. Following patients over years enables us to detect subtle changes, deterioration, or increasing vulnerability. Primary care is also the setting most strongly oriented toward equity and has the greatest potential to counteract the inverse care law. Example of this in that work is the work of Work and Mental Health Roadmap in Spain, a strategy based on primary care and coordinated with labor and social security ministries, focused on identifying and approaching mental disorders caused or exacerbated by the workplace, where integrating clinical assessment, coding, and communication in primary care, especially when a sick leave occurs. This will generate quality data, but most importantly, will help guide case management and make decisions that are better aligned with the true causes of suffering, avoiding medicalization and protecting the most vulnerable people considered gender, class, or psychosocial disabilities. Thank you.
Thank you very much, Paco, for this contribution. When I try to summarize, I've learned from these 4 interesting country contributions that the approach should be based on a broad eco-biopsychosocial lens when we try to look at the problems and especially at vulnerable people, that strengthening primary care with a strong mental health component is absolutely needed and needs careful management, that when it comes to vulnerable groups, that we have to be aware that it is always a complex process and that we should implement changes carefully in order to not create disruptions, and that we should avoid medicalization of social suffering and address the social determinants of health through intersectoral action. So thanks for this picture, and I hand now over to Rachel, who probably has some news from the Mentimeter.
Thank you so much, Jan, and a big thank you to our panelists. That was incredibly informative and really quite interesting. It's such a rich set of perspectives that we've seen, but now we want to take a look at what our audience has told us. And so here are the results from our poll on what are the biggest barriers to identifying mental health needs in primary health care. And, looking at them, a lot of the same themes that we've been seeing and hearing this morning so far, or today. And what the word cloud is actually telling us is quite consistent and telling the strongest signal by far what we see here is stigma. And it appears most frequently across taboo, fear, low acceptance, tendency for mental distress to present somatically. And knowing that in many settings, people are still reluctant to disclose mental health concerns in primary care. In some cases, may not even view primary care as the right place to raise them, or are not aware that might be the right place to raise them. And so I do think that it makes a lot of sense that this stigma would be central. And alongside this, we're seeing a very clear workforce story emerging. Participants participating in primary health care, a lot of it is largely due to gaps in training, in skills, potentially confidence, or overall mental health literacy among providers. And so a lot of this looking to be strongly reinforcing that, continuing to strengthen the mental health competencies, as we've heard this morning as well. And also here, a lot of constraints around time pressure and heavy workload, high patient volumes. So really important for us to see that as well. Overall, I think the strategic priorities that we've been discussing today have emerged, and the barriers to identifying mental health needs in primary health care isn't just about tools, it's also about addressing some of these very pertinent and salient issues around stigma, workforce capacity, and system integration. So I think that this captures a good snapshot, but the time has come now to open the floor to any reflections that our audience might have or questions. And so please, if you could raise your hand using the hand icon, then we can ask you to speak. Or if you'd prefer to post a question in the chat, that's also okay. But if you do like to speak, please turn on your camera and your microphone. So any questions from our audience to begin? And I do see that we've got one question here in the chat box, but I believe that Cassie's answered it, so that's really great to see. Now I recognize I won't be able to see each of the participants, so one of the questions that I had around some of the information that's provided today was just really how can PHC systems strengthen their capacity to identify mental health needs in the population? So I know that we presented a lot of options, very contextually important, but I'm wondering if there's some high-level kind of suggestions or themes around what PHC systems more generally can do to strengthen capacity. So maybe if one of our panelists would like to speak to that first, as some of the questions are coming in or thoughts are percolating. Johanna, I see you've got your hand up. Please, do you want to begin?
Yeah, I can say a few words. I guess my first thought with this is about the encounter itself and meeting the person. That has come up already today, but the importance of being able to talk about mental health in general and normalizing talking about mental health within primary care services, but also importantly outside. And one way to get in there, which might lower the threshold, is talking about mental well-being. So what works, what makes you feel good, and that way kind of approach areas that might be more difficult. That could be one bit, but also just clear instructions also for people within the healthcare sector about how to talk about difficult issues. At THL, we've got a new web online course for talking about suicidal thoughts and suicide behavior to try within our sort of suicide prevention part of the strategy. And there we really kind of go into details about what words to say, how to ask, how to approach, and give workers, but also in the community, the confidence to talk about difficult issues. There's a lot of stigma and there's a lot of myths that surround these kind of discussions. So people tend to be very worried about doing more harm. So it's about encouraging people to be able to use their own way to make good conversations. I think that would be one good way to start.
Thank you, Johanna. Yeah, an incredible point of the absence of confidence sometimes means the absence of questions, but that it doesn't mean that the care isn't there, but becoming more aware of how to ask the right questions, I think can definitely help prime. Edith, did you want to come in as well, please?
Yes, I just thought like to mention that probably the main thing is to find stigma, because until the stigma exists, and so it's very difficult to reach actually the people and to talk to them, because everybody just will hide, like will be afraid to talk about their mental health issues, will be afraid to seek for the help. And more we talk about the mental health, more and more we fight the stigma. So that will help to access the services. And yes, of course, it's also important to train the people, like the general population, for how to recognize people who are at the risk of suicide. So that was a very good point as well. So we have those training in Lithuania, which is also training to people how to talk, what the question to say, and then of course to them navigate for the help. Thank you.
Thank you so much. Really important. So I see that we've got a few more questions in the chat, but Goran, did you want to come in maybe just to finish off that part of the question?
I would like just to say also to don't forget that it's very important working with media, and we work with media more than 30 last year intensively, and we produce also some kind of ethical guideline on ethical reporting on mental health. And from that period, we have much more present topic on our television, and people, they start to talk openly about that. Also having all this network of community mental health centers, practically 75 is a huge number, and for small country, because Bosnia have less than 3.5 million people now. And definitely this visibility also reduce stress, reduce stigma, and involvement of user association. Very active work with user association, and usually they go to talk about health, mental health in TV, and they also participate in every process of our ministry, writing policy documents, writing legislation. And this is something I think very important when we are talking about fighting stigma.
That's a really interesting point of using different channels to start to mobilize, invisible populations, hidden populations. And would you say that this approach alone has been most effective for people who don't self-present to raise awareness? Or are there other strategies or things that have been implemented to also then, I guess, encourage those who wouldn't self-present normally? And that this can go, I see Francisco, you've got your hand up too, so maybe we can put a pin in that question just for one moment, but Francisco, did you want to come in and maybe just for the previous question?
Hi, I'm Clara Benedicta. I work with Francisco at the Commissioner of Mental Health Office in Spain. From the Spanish experience, we wanted to highlight two things. The first one is that it's very important to not focus all the attention in the mental health problems and think about the social determinants of the bad mental health, and make changes from a mental health in all politics perspective, to make changes in housing, in poverty, in discrimination, violence, because if we center the conversation in the social determinants, it makes mental health problems a matter of all people and all levels of government. And this is inherently good because it fights the stigma and does not put all the responsibility in the individual. And that the other idea that we wanted to highlight is that it is important to have more conversations about mental health, but not only focused on mental health problems, and how an individual is feeling about something that is happening in their life, but to start having conversations about what is happening to them that is making them feel that way. And for that, it is very important that the healthcare is accessible, and primary healthcare is the best, that has the evidence that it's the best level to build trust relationships that are not only about mental health, but about social relationship in where you can tell everything, that you can trust your professional of reference, and that fights the stigma and makes an environment where you can tell what's on your mind, and that someone that is listening to you can also put that problem, that demand, in a context, in a social context, a family context, a living conditions, and can give a better response, a more contextualized response. Thank you.
Thank you so much. Yeah, incredibly important. And I do think these elements of trust and accessibility and information also has to line up with a particular time period where people are ready to access support and help. And so it's all of these factors all have to come together. So also having then, the primary health care ready to receive and to act is really important. Great. Thank you so much. I think I don't see any hands. I just wanted to go back and double check for our participants if there's anyone that wanted to come forward and ask a question. I know it can be a bit daunting to unmute and put ourselves forward, but we've got some very esteemed panelists here that are ready to answer any questions. And if not, I can scan through the chat as well. Oh, I see one hand up. Perfect. Romy, sorry if I'm pronouncing your name incorrectly. Romy, did you want to go ahead? Oh, we think we've lost you now. Okay, well, if the question does come back, please feel free to ask. And I might call on my colleagues Anna and Jan to see too if there's any questions that have come up on their side.
There was a question in the chat. People who were not clear about the possibility to have direct access to a psychologist or a mental health care worker compared with the system where you have to be referred by a family doctor. And I think both systems have been demonstrated this morning. So if the panel could comment on how to organize that. So is it direct care to psychologists preferable to a system where the patient has to be referred by a family doctor or another primary care worker to the psychologist? Edita, you want to take it up?
Yeah, again, because we have quite a broad center of the mental health care centers in Lithuania, and I think that works very, very well because the people don't need any referrals to enter the primary mental health care center. It's the same as going to the family physician. So, and this center, we have a multidisciplinary team, and one of the member of the team is a medical psychologist. So they can, anybody who need the help could go straight to the mental health care center and ask for the psychologist. Of course, it could be the waiting list, and because now with this anti-stigma campaign, so we increased a lot of the number of people seeking help at the primary mental health care centers, but still, this I think is a very good model, and it helps for the people to easy and free of charge access. So there's always no cost for the people.
Thank you, Edita. Goran, I think you had a response.
I can say the same in Bosnia and Herzegovina. There is no referral regarding mental health. You can go to family doctors, or you can go directly to mental health services. Usually mental health services, family doctors are in the same facility. But what is also important to say, many people with diagnosis, chronic diagnosis, when they going to the family doctors, they are sent to mental health center to check also the mental health, because very often the chronic situation like with diabetes or cancer, you have people with depression, you have people with problem mental health. The psychosomatic collaboration on psychosomatic issue, it's crucial, it's very important. That's why I think that is good to don't have any limitation, to give possibility to people to decide where to go, to his family doctor or directly to the center. But it's important this collaboration between these two services in the primary healthcare.
Completely agree. Excellent. I see we've got a member of the audience who's wanting to ask a question. Rami, did you want to go ahead and try asking a question?
Thank you so much. So I love hearing all of this, and I really appreciate the input. In South Africa, the integration of mental health into the primary care system, the clinics, has been recognized as the way to go due to lack of access. And it's even within the government white paper. However, we have a problem that this is the political will to fund it doesn't seem to be there. So we've got policy in place, we've got clinics in place, but we don't have the funding for mental health workers. We don't want to put those services onto the staff already existing there, because that would be burdening them with more than they can handle. So as part of a nonprofit network, I'd like some advice on how we can advocate to get those services and those staff in place. How do we advocate with the government or with perhaps outside sources to get the mental health workers in place in primary care?
It's an excellent question. Francisco and colleague, did you want to have a first go at answering?
Thank you, Rachel. For us, it's important that primary healthcare is the first level of contact, because the specialized gaze can be harmful and more reductionist, and the general practitioner, a strong primary care, and the rest of the team can give a more comprehensive approach for the community. I think that the direct way to the specialized therapeutic spaces, I think could be hurtful and to promote the medication and over the diagnosis, over treatment that we are suffer all the Spain, and I think all the Europe also. In that moment, we thought that it's preferred that a stronger primary care.
Thank you, Francisco. I'm wondering if Johanna, if you have any thoughts or comments on that. Did you want to come in?
Me, I'm sorry, you can hear my dogs barking. Someone's just walking past. I just a comment to the our South African colleague. This is a unfortunate but not an unusual problem, that the money doesn't follow the policy, and you asked for some advice on how to do the lobbying. I believe you're from an NGO, so I think you have a lot of voices behind you, hopefully, if you're connected to the to the grassroots, and it's a case of usually pointing out through monetary benefits of attending to mental health, and then looking at those really low threshold options, because if you need to work with a very restricted budget, then these low threshold kind of options might be ones that are most attainable for you, and they do work. So it's not a compromise. It's a good way to start. But I recognize that in a situation where the reform hasn't come so far, and there isn't budget for these changes, it's a tricky situation. But I believe that you will find a lot of good examples from different parts of the world, because you're definitely not alone with this kind of process.
Thank you, Johanna. And Edith, you had your hand up before, but maybe it was covered. I don't know if you want to come in.
Yeah, it's more or less been covered. So I also was thinking to refer to NGOs, and maybe another one I could add is to show in the numbers how much there would be saving of providing good mental health care services. For example, how much it will save because the people won't have sick days leave. So the working population will be working instead of taking sick days leave. How much does it cost to cover sick days leave if this type of the system exists in your country, and how much the mental health affects to the other health issues, for also heart diseases, diabetes, and on all others non-infection type of diseases. So that's maybe could help, but engaging the NGOs and just using them for the advocacy, probably the main topic.
Thank you. Now, I noticed in the chat there was another hand. I think it was Arash. I'm not sure if they're still there wanting to answer, but I think a question that remains to me is still really understanding what approaches are proven, really most effective. And so we've named a number of them. A lot of it's requiring people to come and self-present, but for those who don't want to self-present or maybe haven't had good experiences in the past, what are some of the approaches that seem to work the best in your settings? And we've spoken about a few. But if we want to comment a bit further and knowing that it's not enough to just identify, it's also, reaching out and raising that awareness and building that trust, that's also vitally important. But Arash, I see you're back. Did you want to go ahead?
Yes, thank you for this opportunity. I'd like to ask Sir Goran Serkas, as he talked about the relation between the importance of relation between family doctors and the other specialties when it comes to the chronic illnesses and diseases, and how to tackle and help the patient's mental health and regulate it. So how to make family medicine as a specialty or as a branch in medicine to make the doctors more motivated to apply for this specialty. Since I'm based in Iraqi Kurdistan, most of the doctors don't apply for this specialty because it is very low in income and there's the least of opportunity that the patients are going to see them, and their situations and mental health will be regulated by them. How to make the government and the doctors more motivated to apply for this specialty? Thank you.
This is a question of policy. This is a question for the government, because they have to stimulate primary health care. It's clear that very often the salary is the difference between salary in primary health care and hospital is too high, and I think this is because the ministries and the government, they have a responsibility to reinforce primary health care. And within reinforcement of primary health care, it's important also salary and everything else. It's clear, directly depending of decision of the government, but it's very difficult to have to have primary health care, not to have not enough strong primary health care, because primary health care definitely is a basis for everything. If we would like to have access to health, it's a primary health care. It's not hospital, because you cannot build hospital in every municipality, every community or city. That's why I think that it's clear that value of primary health care and importance of primary health care is very high, and this government must recognize.
Thank you, Goram. I'm just wary of the time. We've got about 5 minutes left, and I see that there's 2 questions that have come in on the chat. So really a lot of thanks for that. So one of the questions, if we can just move before we break, is from Ileana, who would like to know who the manager is in this type of a model where there's no need for referral. So more specifically, is the primary care management in charge of the spaces for mental health, or are they hospital level managed? Just curious if you could reflect on the approach, because it seems to differ quite a lot. So I'm not sure who might want to come in on more of the management of this type of model. And if we're thinking a little bit more around that, the second question is from Umer, who's thinking about what is important when we're thinking about populations, more specifically with those living with HIV or AIDS, around the stigma in society that makes them potentially less inclined to participate in reaching out for health, their health at primary healthcare level. So thinking about how can we look at the different intersections around mental health effects, individuals with multimorbidity, as we've talked about. And so just wanting to reflect on the importance around stigma in members who are vulnerable at different intersections. So this could also be a question for our panelists, or comments more specifically. I'm wondering if anyone wants to come in, weigh in, or it might be okay. Johanna, if you wanna take us to the break, because I know that we've got another segment that might answer actually some of these questions, particularly around more of how adaptations have happened. So Johanna, do you want to finish us off for this part?
Yeah, just really quickly. It might not answer the specific question around HIV and AIDS, but this question came at some point also through the chat about stigma within the healthcare system, and that's something that, of course, also needs to be addressed. We know that people with SMI, so more severe mental illness, have a shorter lifespan or predicted lifespan due to stigma within the healthcare system. They might be less likely to be referred for other health concerns, for physical health concerns, and those kind of needs. So a very pertinent question. Whether we have the answer right now, I'm not sure if we have it here. But again, it would boil down to making the services, mental health services in particular, more based in the community and more accessible, and helping people with the dialogue around it. I think it's one way of doing it, but I'm sure there'll be more specialized options too with these kind of double stigma situations where you might get stigmatized because of a health issue and then stigmatized because of a mental health issue at the same time.
Thank you, Johanna. Yeah, a lot of these questions are not the easiest to answer too. So that leads us to a good time for a bit of a comfort break, and perhaps if I can share my screen again. If we can come back in 5 minutes time, that will be great before we go into our next portion of the webinar today. So what time is it now? So 5 minutes. It's 5 minutes past in the many different time zones that we're in. So if we come back in 5 minutes at 10 past, then we can begin our next portion. Thank you so much, everyone.
So it is now 7:10, and I think we are ready to slowly restart. Welcome back from the break. I hope everybody had a chance to stretch their legs and have a drink or a snack. Let's carry on. This is now the final hour of day one of the conference. So not very long to go, but a lot of important content ahead of us. In the first segment, we looked at how we can identify mental health needs and vulnerabilities. And now we are shifting our focus to how we can adapt service provision to address those needs more effectively. Next slide, please. Yeah, so throughout the session, we will draw very closely on our policy brief and explore real-world strategies from examples that are featured in this paper, as well as from the 4 countries represented in the panel. So I very strongly encourage you to download this resource and read through this paper. Next slide, please. Yeah, so let's briefly recap the 4 strategies for scaling up mental health services in primary healthcare. We have already mentioned them in the opening panel, but it's really important for the session to reinforce them here again. Strategies 1 and 2 focus on building capacity within primary care team, either by upskilling existing staff, which is strategy 1, or by bringing in dedicated health workers with competencies in mental health, which is strategy 2. Strategies 3 and 4 are about building bridges, either by strengthening the links between primary care and specialist services, which is strategy 3, or by building bridges with other sectors like education and housing, which is strategy 4. And we will now go through these strategies one by one, but this is important to stress, as already stressed in the opening panel by my colleague Anna, that they are rarely implemented in isolation from each other. They are all important, they are all closely interrelated and often combined, and you can think of them simply as different entry points towards a shared goal. Next slide, please. Thank you. It is also important to remember that mental health service delivery should be guided by one simple principle. People should receive the right type and level of care for their needs, no more and no less. Usually, this means starting with the least intensive support, like guided self-help for mild anxiety, and then stepping up to structured therapy or medication or more specialist support only if needed. But stepping down is just as important. When somebody stabilizes or improves, the aim should be to reduce support safely rather than simply dropping out of care. This will help to avoid over-medicalization, support recovery in everyday life, and free up specialist capacity for those who need it most. And of course, this approach depends on having the right skills and services available at each step. And unfortunately, in many countries, that full ladder of options is not yet in place. Next slide, please. And this brings us to the first strategy, which focuses on expanding the competencies of primary care professionals. With appropriate training and support, family doctors, nurses, and other primary care professionals can do much more than just spot and refer. They can diagnose common conditions, they can provide brief psychological support and manage transitions. But this hinges on strong foundation in family medicine and nursing and on the availability of further training and support. But if this is available, this can significantly improve access, especially where there are shortages of mental health specialists. But the challenge, of course, is that in many contexts, primary care is already stretched. And adding these responsibilities risks intensifying existing burdens. So one way to manage that pressure is to combine upskilling with other strategies, such as embedding dedicated health workers with competencies in mental health within primary care teams themselves. Let's now briefly look at Sweden for a very good example of how this is done. Next slide. Thank you. So in Sweden, all GPs complete 6 months of psychiatry training during their residency. This allows them to manage mild to moderate conditions directly through counseling and lifestyle interventions, but they don't work alone. Swedish primary care centers use multidisciplinary teams, including psychologists, nurses, and occupational therapists. Specialist psychiatric nurses are particularly key within those teams, and they provide CBT-based techniques and problem management. And because of this high internal capacity within primary care teams, primary care serves as the main entry point, and only about 20% of adults with depression or anxiety ever need a specialist referral. Next slide. So this leads us to the second strategy, which focuses on embedding health workers with competencies in mental health into primary care teams. This can be done by either attaching them into practices while they remain mainly employed in their specialist settings, or by collocating them within primary care teams directly. This makes care available at the primary care level more comprehensive and can take a lot of pressure off the GPs. But the challenge here is the limited specialist mental health workforce, which is the case in many countries. At the same time, embedding these workers in primary care teams is also not always easy, and clear pathways are required to avoid role confusion and duplication of tasks and other inefficiencies. Some countries address these challenges by strengthening linkages across levels of care, in line with the third strategy, which I will cover next. But before we move on, let's take a look at an example from the Netherlands. Next slide. So in the Netherlands, much like in Sweden, GPs are the first point of contact for most people, and are trained and expected to manage uncomplicated mental health concerns. They also work in multidisciplinary teams that include mental health professionals such as psychologists, psychotherapists, social psychiatric nurses, and nurse specialists. And practice are supported financially to employ mental health practice support professionals. And as a result of this, almost every GP practice now has a mental health nurse within their team. And you can think of this as the second part in the mental health pathway, still within primary care, but providing more specialized mental health support. And then more complex cases are then referred to community mental health centers for an even more specialized mental health care. Next slide. So the third strategy focuses on improving collaboration between primary care and specialist mental health professionals, while each remaining in their own settings. This can expand access, improve transitions between levels of care, and also reduce fragmentation, improve continuity. But for it to be effective, it requires clear referral pathways, shared protocols, interoperable electronic health records, ongoing communication, supervision, and other support such as financial incentives. And in some countries, such as Turkey and also Bosnia and Herzegovina, and also as we heard in Lithuania, we see dedicated case managers being used to bridge the gap between primary care and specialist mental health services. Next slide. So in Turkey, community mental health centers work very closely with primary care. Psychiatrists who work in these centers support primary care professionals in managing mental health needs, and care plans for the patients there are developed together with the patient, with the family, and also with the family doctor, so that the physical comorbidities are addressed alongside mental health needs. And an important feature, as I already mentioned here, is case management. Any member of the community mental health center team can take on this role, and what they do is they help to coordinate care across services and support close collaboration with primary care, but also with social workers, so that people receive more holistic support. And this link with social work is especially important, and it brings us to our final strategy. Next slide. So yes, the fourth and last strategy focuses on promoting linkages of mental health services between health and other sectors. This includes public health, education, housing, social protection, but also police, criminal justice, employment services, as well as public and private workplaces. And the aim is to enable a more holistic approach to mental health, an approach that recognizes, as so clearly highlighted in the opening panel, but also in the previous segment of this session, that the social determinants, environmental factors, and the wider societal context are a major influence on our mental well-being. At the same time, there are also challenges. Cross-sector partnerships are complex, and collaboration is not always easy to establish. This is because there are different funding streams between different sectors. The organizational cultures differ. There are different accountability structures and many other factors. But despite this, there are strong examples of effective cross-sector working. And Belgium is one such example, and I will speak about it next. Thank you. And of course, Jan, please feel free to come in with more details. So in Belgium, mental health reforms have aimed to shift care away from psychiatric hospital beds and towards community-based services, and especially since the COVID pandemic, to strengthen prevention and early detection, especially for mild to moderate conditions. And a key mechanism is their regional mental health networks. I understand these networks coordinate pretty much everyone. They coordinate outreach teams, primary care, inpatient services, and very importantly, vocational and housing support and social services as well. They assess social needs and allocate budgets across sectors to ensure that care is organized around the person and not just around their medical diagnosis. Next slide. And yes, so as we head to our second country panel, let's very briefly recap a few lessons from this brief overview. So first, mental health care has to be matched to the intensity of need. Stepped care requires being able to safely step support up or down based on the individual. And this only works if there is real mental health capacity at every level of the system, not just at the specialist end. A second message is that strong primary care is the foundation. We need family doctors and nurses who have the practical skills and confidence and not just awareness to actively manage mental health. Third message is that multidisciplinary teams matter. Embedding health workers with mental health competencies directly within primary care teams makes support more comprehensive and coordination with specialists much smoother. Fourth, we should look upstream. As access improves and more needs are identified, we must prioritize prevention and cross-sector collaboration to address the broader factors that impact mental well-being. And the final point is very simple. None of these strategies works best on its own. They are complementary and mutually reinforcing. And the greatest impact comes when they are pursued together as part of a coherent approach. Next slide. And yes, thank you for listening. That is all in terms of the introduction to this segment. We will now start the second country panel, but before we do, Rachel will launch us into the second Mentimeter survey.
Excellent. Thank you so much, Anna. That was a really great presentation, and definitely just pulling out the salient messages from the brief. And but first things first is we want to come back to the audience, and I do recognize that there's lots of questions in the chat, and it is a bit challenging to kind of weed through. So if you are able to put them in the Q&A function, I know it's a separate ask, but it will be a lot helpful for us because we want to hear from each and every one of you. But one way of doing that is through these Slido polls. So we've got another poll coming in. Now this one is going to be more of an open text. So asking what are the most important actions to scale up mental health services in primary care and the community. And this is, from your perspective, from your context, what are the most important actions? And so you can write in as many responses as you'd like, and we'll come back to this, the results again after we hear from our panelists.
Okay, thank you so much, Rachel. I would now like to welcome back our panelists. In the first country panel, we have discussed measures to improve early detection. Now, in the second panel, we'll look at countries are adopting primary care services to provide mental health support more effectively. We will carry on in the same order as in the first panel. So we start with Finland. Johanna, in your country, primary care is really the main door for mental health. Could you please explain what makes your primary care system to be such an effective first point of contact? Over to you.
Absolutely. We have through the strategy, like I mentioned previously, really kind of worked on different parts of the primary care system, and especially adapting it for certain groups. If you go to the next slide, you'll look. You can see again a pyramid. We've had a lot of pyramids, which is very very good because they show a very important message. This is an example from the strategy, which is working towards point 2, which is supporting children and young people. And the process here, again, clarifies this stepped approach, which has been mentioned many times, to mental health care, beginning with sort of a lower threshold stuff at the bottom. And then the further you work up the triangle, the more specialized it becomes. We've even sort of added another layer in here, which is the one in red here, which I'll go through just now. So for this to be possible, we've had to build a lot of competencies around mental health for primary care. And it's based on a psychosocial approach. So looking at these very low threshold kind of approaches to supporting people, sort of more people with, at an earlier stage where the symptoms may be less severe. So at the bottom here, we have the largest area where the biggest amount of work should be taking place. And here we've put a lot of emphasis on digital methods and digital solutions. Of course, digital solutions are not for everyone, and we need to be aware of that. But they do also provide an opportunity to reach people that are difficult to reach. And in Finland, we're a very long country, we're very sparsely populated. So we do have a challenge in making sure we meet people's needs. Meeting people's needs within primary care is an issue that we are working on and an issue that has been highlighted. So these digital methods might give us an opportunity to meet some of those needs. So these digital methods are sort of guided and unguided self-support through different platforms, and also looking at accessing support. So you can go through various navigators and look at any need that might be there. And then if you move up the triangle a little bit, we come to more sort of symptomatic treatments or preventative treatments. And here focus has been on short interventions. A lot of people do well on fewer amounts of meetings. And then, of course, developing the community on the outside of this triangle. So making sure that we have opportunities to promote our mental well-being at the same time is very important. And again, integrating different areas and integrating social support and all the other personalized kind of approaches that we need to have in there. And then we have this treatment of mild and uncomplicated disorders, which can be used, you can do a combination of these brief psychological interventions. And then at the top, we have more specialized treatment. So that's something that we have worked on a lot in Finland, and like I said, developed the competencies to be able to work through. And also, of course, improving this integration between specialized services and primary care. So the next slide is an example, again, from the sort of governance perspective, which has been adapted recently, is making sure that young people have access to these low threshold support options. And we've actually generated a new law which safeguards support for young people under the age of 23 within a short period of time. So I think it's 29 days that they have to be able to have some sort of support. So when people were talking about hanging out in the queue or feeling worse in the queue, I can't remember exactly how it was put. It was put in a really good way. So it's really tackling that problem for young people in particular. And of course, focus is then to try and broaden this to other age groups, but we're starting with young people at the moment. So strengthening the sort of early intervention side and ensuring clear pathways, working from the bottom up. Now I've lost track of time, so I don't know if that was 5 minutes or not.
Thank you, Jo.
That's great. Thanks so much. Yes, you mentioned. I'm just going to recap a few things that I noted down. You mentioned strong competencies in mental health in primary care, which I guess that's the main factor that makes primary care the main door for mental health services, for accessing services. It's also important to emphasize your point that a strong entry point doesn't mean the only point. You show the pyramid. Primary care is not the only entry point for mental health services. It's about having multiple ways for people to find health. And you also mentioned digital solutions, which is a topic that will be covered on the second day of the conference, also important for the younger generations. And that therapy guarantee that you mentioned is a really great example of a governance of policy that turns commitment into a time promise for support. And I'm curious if there will be follow-up questions from our audience, how you implement it in real life, if there are shortages of professionals, is a high demand, how do you make it, how do you implement it in practice? But we can come back to that in the discussion later. Yes, thanks so much, Rachel, for moving the slides. We are turning now to Lithuania and Edita. In Lithuania, reforms, as you already explained in the first panel, you mentioned that the reforms focus on expanding direct access to community mental health centers, which in many ways operate as the main or the first provider of mental health support in your country. Could you explain how this model works in practice and how primary care is really connected to it currently? Over to you.
Okay, thank you. Maybe we could go straight to another slide, which is also about reform. So I would like to introduce what the reform was. Mainly focused on creating the patient-centered system that prioritizes recovery and human rights. The goal is to transform services by reducing inpatient care, but for that we need to expand community-based services. That's for sure. So these reforms aim to achieve measurable improvement by 2030. This means to reduce the number of psychiatric patient beds by 30%, lower suicide rate by 40%, and decrease the hospitalization rate by 33%. So as it was a very high expectation we have of 2030. But this is not easy, I will be honest. So Lithuania has a long-standing system organized around the inpatient care, and transforming it while motivating services to operate differently is challenging. As in many countries, we also face shortage of the doctors and other healthcare specialists, particularly in rural areas. And as a result of all those challenges, change on the ground is happening more slowly than we would like to. So still facing a lot of the challenges. So the next slide. No, not this one. About the mental health care centers.
Thank you.
Well, yeah, I will talk. Yeah. So in Lithuania, we have built a network of more than 100 mental health care centers. And for such a small country, which is less than 2 million inhabitants, is quite a lot. So those mental health care centers covers nearly all municipalities, except the two smallest, which are very, very small. So this centers brings together multidisciplinary teams to providing care for both adults and the children. So but the beginning of the year 2025, we divided those teams into two. So one is providing the services for the adults. So this team includes the psychiatric, clinical psychologist, mental health nurse, social worker, and the case manager. The case manager plays the key role here. So they coordinate the care for patients, help them to navigate through the services, to follow the treatment plans, and to connect with social or community resources. So this ensures the continuity of care and prevents patients from falling through the cracks, as I would say, and support recovery in a holistic way. And very important that the case managers that are working with the patients who are not motivated and not seeking for the mental health care services, but they really need it. So it's very hard work for the case managers, but very, very important. And to help the case managers, we prepared the recommendations for organizing and implementing mental health care management and the provision of the services, and which helps for whole country, for whole Lithuania, to provide the same type of the services and to understand in the same way what does the case managers need to do. And also provided the training for the healthcare managers for mental health care case managers. So this to make sure they will be trained before they start providing services. For the children and adolescents, we have a separate team which includes child psychiatric, medical psychologist, and the third team of the member of the team. So it could be the mental health nurse, it could be the art therapist, social worker, case manager, or extra medical psychologist. And it's important that we're also planning the training for this team to ensure that they all are prepared to work with children and adolescents. So this requirement also very new is started going in the steps. So started from the last year, second part of the last year. And until 2027, we are planning to have all services provided to the children and adolescents must be provided by the separate team. Also, what we did to ensure the better access to the mental health care center, so we reduced the amount of the patients or amount of the population that is serving this team. So it used to be at the beginning of the services was the 20,000 of the population, then reduced to the 17,000 population, and now up to the 15,000 people of the population. So, but it doesn't mean that they all seeking for the help, but because we have the same system as for family physicians, so that all the Lithuanian inhabitants are registered to the mental health care centers, regardless they're visiting or not. And a psychologist serves up to the 10,000, so it's even more expanding because of the psychological help. And for the children and adolescents team, with the smaller population, is only 8,000 inhabitants. So, and also in those centers are provided services for like the short psychotherapy at the primary level, also for suicide prevention, the services, and alcohol risk assessment and psychomotor development checks for the children. And this model, I would say, is important because it makes mental health care more accessible, coordinated, and consistent through the whole country. But as I mentioned before, it's not easy to make it work in such a short time. And we still have facing some challenges. And in that system also we have a role of the family physicians, which, as I mentioned before, they can treat some mild mental health issues. Like for the postnatal depression, for example, they also, the first point that the woman's visiting, so they are obligatory to ask the few questions for all women who just had a child in a half year. So, and if they see the symptoms.
There's a final point.
Yeah.
And we'll have to
Okay. So basically, this two system is connected between each other. Yeah. So this is the map where you can see how widespread this network is in Lithuania. So the big marks is the big centers, and the smaller ones are all around Lithuania. So thank you. Again, I could talk and talk, but I understand I have a short time, so thank you.
Thank you so much, Edita. There will be time to talk later. But thank you so much for your great points. You have brought the perspective of a health system that is historically hospital-based, and you mentioned the challenges of transition. You talked about removing the need for a referral, but also geographic empanelment as important steps to lowering access barriers to mental health services. You also mentioned the role of case manager, which is interesting because it sounds like more of a motivator for people who are reluctant to seek care. So I wonder if our participants will be curious to hear a little bit more about this role and what it involves, because it doesn't seem like a typical maybe case manager role. And at the same time, you also mentioned capacity constraints. You are rolling out the community mental health centers, but that means that you need to have mental health professionals available, and perhaps there are shortages of psychiatrists and other professionals. So I was very happy when you also mentioned the need to, at the same time, reinforce mental health capacities in primary care professionals. And you already mentioned that they take on the management of a range of conditions. But let's now move to Bosnia and Herzegovina. Unfortunately, Goran had to leave, but we have Ida with us. I think Bosnia and Herzegovina offers a very interesting step coming in after the intervention from Lithuania and showing how structured collaboration between community mental health centers and family medicine teams can work on a day-to-day basis. And also you'll be talking about the role of case managers as well. So could you walk us through how these roles and these structures function in practice in your context, please?
Hello, everyone, and regards from sunny Sarajevo. I noticed that Lithuania has similar shape as Bosnia, which is very interesting. So I would like you to move to next slide with the chart. You have opportunity to see this chart earlier this day when Dr. Cherkes presented prevention services of community mental health centers. Bosnia and Herzegovina has developed a nationwide network of 75 community mental health centers, of which 45 operate in the Federation of Bosnia and Herzegovina. You know our country complexity and so on. I do not need to explain. These centers are not specialized institutions separated from everyday life. They represented the main entry point for mental health care in the community and play a coordinating role between health services and other sectors. The first key element of this model is that care is delivered close to communities. Community mental health centers provide multidisciplinary services that are not limited to the center itself. It means that, as you can see from the chart, that center is connected with all sectors of society, such as social sector, educational sector, centers for migration and civil society organization and international organization, and so on. This is mainly important for vulnerable populations such as migrants, socially isolated people, and families under chronic stress, because it reduces barriers related to stigma, transportation, and lack of information. A very strong component of service delivery is the close collaboration with primary healthcare, especially with family medicine teams. Family doctors are usually the first professionals who identify mental health needs, including psychosocial difficulties related to chronic disease, family stress, and school-related problems among young people. For this reason, community mental health centers and family medicine teams work through joint meetings, protocols, joint education, training activities, and other activities. And this is a two-way referral system. It is very essential for this kind of services to young people. And let me explain how this works in practice. People identified in family medicine are referred to the mental health center for specialized support, while people receiving mental health treatment are usually referred back to family doctors to ensure their physical and psychological needs are addressed, to make sure that these needs are addressed in an appropriate and integrated way. In this way, mental health care become part of everyday primary health care rather than a parallel system. Please, can we move to next slide? Another important issue in recent years is increasing recognition of mental health needs among children and adolescents. Cooperation with the education sector is therefore a core component of the model. Schools and teachers often identify early emotional and behavioral difficulties and contact mental health professionals. In practice, this includes joint meetings between school staff and the mental health professionals, counseling for students, and guidance for parents and teachers. Special emphasis is placed on preventing and transmission of trauma across generation. Probably Dr. Jackers spoke about this in the first session. So I will move to the importance of multi-sectoral cooperation. It is on the previous slide, please. Okay. Beyond health and education, Community mental health centers are strongly connected with social services, NGOs, community organizations, and local authorities. This multi-sectoral cooperation is especially important for migrants and other socially vulnerable groups whose mental health needs are often closely linked to housing insecurity, legal challenges, poverty, and family separation, and other problems. For example, when a migrant family is identified as being under stress, the mental health center works together with social services and civil society organizations that work with the migrant population in order to ensure the psychological support, family counseling, and social assistance. All these services are provided at the same time. In this model, community mental health centers function as a connecting connecting hub between health services, social protection, education, community organization, and local government. Next slide, please.
Perfect. Maybe just your summary, key summary points. Thank you.
Yes. And finally, I would like to emphasize the role of case management, which is central to ensuring a continuity of care for people who require longer-term support. An individual recovery plan is developed. Each person is assigned a case manager based in the community mental health center. The case manager coordinates care across sectors, monitors the implementation of the recovery plan, maintains communication with families, and supports transition between services, for example, between healthcare, social services, education, and employment support. The role is very important for migrants and young people because their recovery often depends not only on clinical treatment, but also on stable social conditions, access to education, and successful social reintegration. I think that I fit the time now, or no?
Thank you so much, Aida.
Thank you very much.
Thank you. Thank you so much for your intervention, and thank you for emphasizing so many points that came up through our 4 strategies. You have spoken about the strong connection with other sectors in the community, but also you brought in some concrete examples how this works through joint meetings. I think you also mentioned guidelines. You also emphasized the strong connection between community mental health centers and family medicine teams. And you spoke about the two-way referrals, which is very important, referring to community mental health centers, but also from the centers back to family doctors to make sure that the somatic needs are also addressed. And also you really made a good point explaining the role of the community mental health centers as the connector, the connecting hub, I think you called it, among all these actors in the community, with a very important role of the case manager who connects all these various actors around the patient, the person at the center. So that's really great points. Thank you so much. Let's now move to Spain. We already heard in the first country panel that the integration of mental health services goes really far in Spain, and it builds on multidisciplinary teams and relational continuity and strong links with community resources. Paco, could you tell us a little bit more how this approach works in practice?
Thank you, Anna. Can you put the slide? The next slide. Okay. If we want to respond effectively to mental health needs, services must adapt. One promising approach is the integration of multidisciplinary mental health teams within primary care through collaborative or hybrid models. These teams work from a community-based, socially informed framework and often have expertise in group intervention, large community groups, and systemic approach. An important part of this model is strengthening mental health competencies among primary care physicians and nurses rather than substituting them. In fact, primary care already has the competencies and condition to take care of the most complex cases. We believe that introducing excessive specialization in primary care can lead to fragmentation instead of promoting that every member of the team develops skills to respond in a comprehensive and meaningful way. This includes shared case discussion and reflective spaces such as valiant groups, which allow clinicians to reflect on the relational and emotional dimensions of care. Social workers play a central role. Alongside them, other professional profiles such as occupational therapists, educators, or social integrators could help shift the focus from the clinical to the social and community dimensions of suffering. Coordination with specialized mental health services remains crucial, especially in more complex cases. However, the model we are trying to implement is not a rigid step care system in which each professional operates only at a specific level. Instead, it's a shared care model. Responsibilities are interwoven, and professionals collaborate flexibly according to patient needs. Competencies overlap rather than being strictly segmented. Next slide, please, Anna. Finally, I would like to emphasize relational continuity. Long-term relationships with primary care professionals are, in themselves, protective factors for mental health. Continuity is not only an organizational feature, it's a therapeutic intervention. The therapeutic relationship is central to our work. Knowing the patient's biography, family dynamics, and social context allow us to understand how life circumstances are linked to distress. Before labeling or diagnosing, we should be able to explore with patients how their suffering relates to their lived experience. This requires training in community-based models, prevention strategies, do-not-do approach, and quaternary prevention. Knowledge of the neighborhood and his health assets, social, cultural, civic, and recreational, also strengthen our capacity to respond meaningfully. Continuity facilitates early detection, shared decision making, and appropriate referral. Referral should not mean transferring responsibility because this is not mine. It should be shared and accompanied, referring without abandoning the patient. Ultimately, this is a commitment to person-centered care rather than a diagnosis-centered care. A good example of a project funded directly by the Ministry of Health are the mental health emergency and recovery units established in the autonomous community of Valencia after the devastating floods of October 2024. These units are designed from a psychosocial and multidisciplinary perspective, rooted in primary care and with a strong community focus. The initiative involved the recruitment of 52 professionals deployed across 13 units in the most affected districts. These teams include psychologists, social workers, occupational therapists, social educators, social integration specialists, and nursing staff, all trained in community mental health and emergency responses. They were deployed last summer and will remain in the field for 16 months. Their approach is collective and community-based. They facilitate spaces for shared grieving, support victims' associations, and act as a bridge between primary care and social services. A key objective is preventive mental health, maintaining close daily contact with affected communities, reducing the surge of in-demand on primary care and avoiding over-diagnosis and over-treatment. Many emotional responses in this context are intense but normal reaction to extreme events and should not be pathologized. At the same time, the teams ensure that those who do require the specialist care are appropriately identified and supported. Thank you very much.
Thank you so much, Paco. Really, you have highlighted so many important things, but I think what's struck me the most is that idea of the relational continuity and knowing the person is a therapeutic tool in itself, and that's a very powerful message that you brought across. And also, it reinforces your points about avoiding the over treatment and keeping support grounded in a person's real life and community. And you really have given us plenty of inspiration for the discussion, but unfortunately we are only 10 minutes away from the closing. So I will just wanted to express my sincere thanks to all our panelists for your incredible insights. And let me just hand over to Rachel to show the Menti results, and perhaps we can sneak in one or two questions before we close. Rachel.
Thank you, Anna. I'm just seeing what's coming up here now, which I don't think it's showing any of the results. So what I'll do is just remind you of the question, because it doesn't come up as beautiful pictures. It's just the words, the descriptions of what you had mentioned. So thank you again so much for your votes. And it's really clear, not that you can see, but to me on the back end, it's very clear that there's several priorities that do stand out from your responses. And a lot of your responses had really emphasized the need for cross-sectoral collaboration with better communication, coordination, and PHC community orientation. So the need to integrate mental health explicitly into PHC reforms has really come through, and that's done through truly integrated services. So a lot of what has been discussed here today. A lot of your responses also had highlighted building competent primary care workforce, and bolstering and improving capabilities and capacities that are already there, but maybe underutilized at this point. So the training was a big one that came through, multidisciplinary teamwork, better working conditions, and a lot of things that will be touched on tomorrow. Many of you called for expanding community-based mental health services, ensuring easier access to comprehensive community supports, and themes of decentralization, but also telemedicine or digital interventions were quite relevant. So big overarching support for empowering people with lived experience, supporting families, and also addressing stigma. So I think those are the key themes that have really come up for me today. And then finally, the importance of resource allocation and funding, and again, more of that discussion tomorrow. So really, again, thank you for your input. That helps us just to kind of see that we're all on the right track here. And unfortunately, with what Anna had mentioned, that we are drawing to a close for today. But with this in mind, so some of the questions that did come up, I tried to think through of what were some of the themes, and they're really thoughtful questions and quite consistent around a strong cluster around mental health workforce. So a lot of you were asking around who's actually delivering the care on the ground, and particularly in the role of case managers, also raising important concerns about workforce capacity and incentives. Secondly, there were some questions around model of service delivery. So whether if there was interest in countries that have moved toward more community-oriented models of care, how mental health was positioned within primary health care, and whether the private sector had been engaged. Two more points kind of around questions, and maybe the panelists as a final thought can reflect on some of these. But third, you had also questioned around that there needed to be broader systems around the integration and breaking down of silos within primary healthcare. So a lot of you are asking around how health systems in this region are advancing more holistic and cross-disciplinary approaches. So not just thinking of medicine in the traditional sense, but more of the potential role of integrative medicine, and whether systems were really structured and ready for that full spectrum of coordination of care. And finally, the importance on evidence and analytical tools. So with those questions in mind, and I know I didn't do service to all the specific questions that have come in, but if our panelists could do as one piece of advice, what is the one piece of advice you would give to countries that are just beginning to scale up mental health services within a primary healthcare approach? And so thinking of all of the questions that have come through, but if we got one piece of advice, I'll turn the floor back over to our panelists. So if we want to do maybe in the order which we presented, that would be great.
Okay, yeah, I've got the easiest job then because I'm first. I would say use what you have. I think there's a lot that is being done in the communities, but it's just not being recognized as mental health work. This is especially true when it comes to mental health promotion. There's a lot of stuff that's going on that hasn't been framed in that way, hasn't been measured, hasn't been attended to, and kind of given the attention that it deserves or could have. So I guess just, yeah, checking what there is already resources in the community and making use and showcasing them.
Thank you, Johanna. Edith, I believe the floor is yours.
Yeah, thank you. Just thinking, I don't know what the one main advice would be. Maybe to have the multidisciplinary team, it helps a lot. Not to focus only on the mental health physicians, but include the team as wide as possible. So not necessarily only psychologists, maybe some people who are trained to provide first mental health support. So that also would help a lot. So probably that's my main advice.
Thank you. Ada.
I think that in order to improve mental health, we need to multi-sectoral approach in strengthening capacities of all sectors: local community, civil society organization, healthcare workers, and education sector, and each part of the community. I think that everybody needs to be educated enough in recognizing health problems, and I think that we have developed a kind of strategic document at the community level in order to raise awareness and approve and increase capacities. Maybe I was confused, but I think that the message is clear to you.
Thank you. And last but not least, our colleagues from Spain.
Thank you. Primary care intervention must be carried out in accordance with the core values of primary care: accessibility, universality, continuity of care, community-based work. If we impose hospital-centered logics, diagnostic labeling practices, and fragmented perspective of mental health, those core values lose their strength. A primary care perspective must be centered on the person's needs, biography, and context, and develop and co-construct interpretation of what the problem is and what is useful to solve it. Reducing all of that to a psychiatric diagnosis label can be all of little practical use and sometimes can become openly harmful. It conceals social determinants, depreciate biographical, relational, and collective dimension of suffering, and reduce distress to an individual, brain-based, mainly biological problem. Thank you.
Thank you so much, Paco, for these final words, which actually fits very well with closing, because you do mention the importance of the primary healthcare approach and centering on the person, but also focusing on the socioeconomic and other broader determinants of both somatic and mental health. So with that, we have now come to the end of this deep dive session. On behalf of my co-moderators, Rachel and Jan, I would like to sincerely thank our panelists for their excellent contributions, and to all of you for joining us today and for your engagement throughout the session. Please do join us again tomorrow for the second day of the conference. And tomorrow we will be exploring topics such as health workforce education and training, sustainable funding and financing, as well as digital technologies for mental health. So thank you once again for your time and your participation, and we look forward to seeing you again tomorrow. Goodbye.
Thank you. Bye.
Thank you all. Bye.
Bye. Thank you.
Thank you.
Thank you very much.